we are able to interrupt the circuit by doing a line from the IVC to the tricuspid annulus. It's fine. So let's see if we can open the right ventricle and have a look. They don't put blades on this thing, no? Yeah. No, blades. The blade handle is there. Let us see.
Brand and the right bundle going through it.
Yeah, so right ventricle, once we open, we'll see if we can show those.
It's from the other side.
Yeah. Be like this. Yeah, I don't know if it's the correct one. Yeah, let's see. Is sort of okay, or it will slip off. Yeah, it should be okay. So, like we said, we have the interventricular groove here. You can identify that. So let's sort of open it a little near the interventricular groove. Is inside, I think. Okay. So this probably no.
Yeah, that looks like.
Yeah. So when you so that's why it's sort of called the moderator band. No, sort of it prevents the RV dilatation. That's what they say. So it bridges from the septum to the free wall, and on the right side you have the inflows and outflows are separated. So you have the inflows coming from this side, from the tricuspid valve, and then you can see the going on to the pulmonary valve here. And between these two, you have this band. This is the infundibulum, right? And then, so what happens is the right bundle comes along this and come here, and then from here it will cross over through the moderator band, reach the base of the papillary muscle. You can see here, there's a papillary muscle there, and then spread through to this, right? So that is this. Again, you can see a lot of trabeculation is more towards the apex, which is why if you're putting passive leads, this is where you'll get good fixation. Whereas when you come here, you don't have that much trabeculation, but you can put active leads. And again, here, true ventricular, like all that you see is not ventricular septum, which means like if you puncture here, you'll you can see this is actually free wall, right? So just because you see in LAO that it's pointing this side doesn't necessarily mean it's septum. Actually, it often tends to when we try to put a septal lead placement, it usually tends to fall into this anterior interventricle, this area of the right ventricle, because there's like a, if you know, the right ventricle is like a crescent, right? It tends to come and fall into this. So that's why what we try to do, and what is
placed in the anterior wall.
Yeah, so this becomes a free wall thing, even though you think you're put in the septum. So in an RAO view, you should try to see that you're more in the middle of the cardiac silhouette, not going to anterior or posterior. And then
show them about a catheter coming into the tricuspid annulus.
Yeah.
How when you want to talk to 9 o'clock position, you need to move the catheter further in so that you are at the AV group. So if you don't move it further in, you will actually fall off into the RA as you give your talk.
Okay, so you're talking about mapping right free wall pathways.
Yeah,
correct. So with so this is the tricuspid valve and this. So I don't know, the best would have been to show it from the atrial side, right? So this is the IVC. Let's see where the IVC is exiting. So this is the IVC somewhere here. IVC. From the beginning, we have not been able to find the IVC properly. Actually, this looks like the IVC. But it was because of, okay, this is the IVC, right? So this is the IVC. Okay. This is IVC. What John says, your catheter comes like this, and then you will be entering the tricuspid annulus. And then, so the natural curve from the IVC will tend to take blood towards the fossa valis, right? So because that's how fetal blood flow, if you think, right? So the SVC will come towards the tricuspid annulus. So when you put a catheter from there, you'll naturally go into the tricuspid annulus. IVC will tend to take you towards the atrial appendage and the fossa. So it will tend to go like this. And you flex and enter the tricuspid valve. And the tricuspid valve, so medially here will be the His bundle. So what John says, when you're mapping up more laterally, you want to move, right? That's what you're saying. Yeah. If you maintain the same thing, like you don't push the catheter in or out, and with that same orientation as you come laterally, you'll tend to fall like this into the atrium easily. So you're saying we need to go a little more ventricular before coming this side. So mapping the annulus is something that you have to get used to. It's not a simple, straightforward 2D structure that you just move laterally and you'll come to the thing. Like he says, the planes vary and you have to take a call on.
So basically you go into the annulus, get a good A and a B signal, so you know you're on the annulus septally. Now let's say it's a atriofascicular pathway, you want to go 9 o'clock position. If in the same plane you move 9 o'clock, you will go straight into the atrium, as Raja just showed you. As he's moving laterally, it's going straight out to the atrium, because your AV ring is like that. So when your catheter has to move laterally, if you were to sort of torque from here, you will automatically fall into the atrium. So you need to move further ventricular and then torque. That's when you will maintain contact with the AV group on the lateral aspect.
And this is the pulmonary artery, so this is where your outflow tract PVCs will be mapping. And you can see the outflow tracts at this point, like see this is pulmonary artery and this is aorta. Really the relationship is almost anteroposterior. They are not really right and left. It's anteroposterior. And when it starts off, the RV outflow tract is to the right. It's right and anterior. But as it curves, it becomes left and anterior. So this part is a little complex to understand and orient yourself to.
So note that the pulmonary valve is at a higher level than the aortic valve.
The pulmonary valve will be higher. The aortic valve is going to be low, right? The pulmonary valve is the highest valve.
So when you're ablating in the upper part of the RVOT, you will be right next to the left main, as he'll show you.
So that's an important thing, that underappreciated how close left main is when you're ablating from the right side. If you're ablating from the LCC, we always think left main, you're close to it. But in the right, again, a lot of the arrhythmias are more posterior. And when you're posterior, like John said, you're going to be right against the aortic root and where the left main comes off. So it, again, just have that orientation in mind and you can be fairly close to it. So it has a relationship to the RCC also. And then as you go a little more distally into the LCC, because it's crossing from right to left. So that is about the right side, I think. Let's see if the left atrium, we can open a little and see the left atrium. So these are pulmonary arteries. This is the vein. This we already saw. Right through this. Still not sure if this is. Maybe we'll incise across this and then open this and see. So this is the pulmonary artery. Is it coming out? So that's what, these are all PA branches, right? And This is also PA. So this part I'm still not sure of this pulmonary. This is the pulmonary vein only, right? So this is the left atrium. This is the left atrium. Yeah, right. So we can just open this. That's this. So like you said, is the pericardium, I think, sticking onto that. This is the left atrial free wall.
I'm not able to see the PVs opening into the
Yeah. This area where they've taken the heart, all the things are a little mangled, so. Yeah, so this is the left atrium now. So again, we have the left atrial appendages at this side. So again, you can see towards the left. So the anterior part is all the pectinate muscles, and then you have the smooth part where the pulmonary veins are draining. And so this is the left atrial appendage. Right. So this is the left atrial appendage. So where we opened was the left pulmonary vein. So this is the left pulmonary vein, and this is the left atrial appendage. So between these two is the ridge. Again, not that prominent in this heart. Sometimes you see it much better, but this is basically the same infolding that you're seeing from here, right? So here you can see the infolding here. This infolding will form a ridge here, right? So when you're trying to isolate the left vein, you're here, and then you'll fall into the vein or you'll fall into the left atrial appendage, and that is where the stability along the ridge is a little difficult at this part. So that is that, and then I can't really see anything else here. And this we already showed you when we cut this, we've opened this, but this is the foramen ovale and that region. Anything else here on the left atrium? Yeah.
Papillary muscles.
So left atrial, again, posterior wall, you have to remember the relationship to the esophagus. And like we said, right pulmonary veins, remember the relationship to the phrenic nerve, and also the right pulmonary vein relationship to the SVC and right atrium, so that you can confuse arrhythmias which coming from it. Right? So I think the last part we'll open the LV. Is obviously much thicker muscle. So. Right. Okay.
You see the posteromedial papillary muscle there, which is very septally located.
Yeah, so you have the main posteromedial and an anterolateral papillary muscles. You have the mitral valve coming from here, right? And then you'll have the aortic root going off from this side. Let's see if we can demonstrate that. Right, so it's sort of hidden by the anterior mitral leaflet. So this is the aorta, right? So this is the LV outflow tract, and here you have the continuity. So this is the place where the aorta and the AML are lying in continuity, and what we call the AML, the aortomitral continuity. And then the papillary muscles we saw here. So you can see this is the anterolateral, and then you'll have a posteromedial papillary muscle here, which we have partly cut through. So that is the papillary muscles. And then I think these are all the chordae, but sometimes, like we saw a moderator band, you can have a false tendon on this side of the heart
So when
also.
you're doing a papillary muscle VT, your catheter has to sit on that papillary muscle, but it will fall into either the groove this way or the groove that way.
So you can see
You
it's
can
a
see
very
grooves on either
complex
side.
structure, and yeah, like John said, you can see a lot of grooves, and then you have to sit on the papillary muscle. So your 3D map will mainly be showing you the outermost walls, and this is sort of a protrusion inside, so you may not see it well.
Once
unless
you
use
fall
some special
into either
techniques.
groove, you can't just move like that to come back on top of the papillary muscle. You have to pull your catheter back and then again come.
Come and sit there.
Because that's very important to understand by seeing that.
How will you know we are just feeling?
Yeah, by feeling. When you're trying to move, you're not able to move where you want to move. Then you have to pull it back and again come back to lie on.
Fall suddenly, it means we are off the.
Yeah, you're off the papillary
And
muscle.
this is where imaging is useful.
Ice is very
Ice is very, very useful for these, because you can see where you are in relation to the muscle. And this is the, so we discussed the other way to access a little bit of the summit region. So you come down from the aorta, you can see how thick this muscle is, right? So you're going to endocardial aspect you can access from here. So in the summit, sometimes the PVCs may be more endocardial, and you might get it from an endocardial. But if you do endocardial, this is a place where you can do high power ablation, little prolonged, so that you produce a deep lesion to get access here. But
You can also show them the Gerbode defect area where the RA and LV come in contact, which is where the penetrating bundle of disc will come into the left side.
so from the right side, we said, the apex of the triangle of Koch, the membranous septum, because the tricuspid annulus, of course, is
It's
the,
more apical compared to the mitral annulus.
so just above the tricuspid annulus, if we put if you puncture from there, you'll reach the LV side.
LV.
Right, so that's one way of reaching the LV, that's what they're saying. So here it might be different.
Region we can operate from there.
Yeah, so they say that, yeah.
But that's also where the His bundle and conduction system is going. So it's not an easy area at all.
So the relation of the LV summit to that.
So that's what, so the summit is here, right? So the main one way to think is first is the great cardiac vein, right? So the main thing is the great cardiac vein comes along this. So in an EP, that's what we're going to do. We put a coronary sinus catheter, push it deep inside, and you'll see it come all the way to the anterior interventricular groove and just start turning down as the AIV, right? So that area we place a catheter. So that is the great cardiac vein. Then your from the left coronary cusp, left main will come there, and it will divide into the left anterior descending, which comes here, and left circumflex. So usually these form a triangle. So the left LAD, LCX, and then the GCV will cross like this. So this area is usually the summit. So that is the summit, and then like you can see here, the atrial appendage is in close relationship, and then the LCC also becomes a relationship. And you can see if you go epicardial, see this area is just covered with so much fat. So if you have something here, this is not really a place to access from a pericardial approach. So on the epicardial side, the best access is from the coronary sinus, from the GCV itself. I think that's about it. So we'll. So fascicular VT area, see the thing is, so in an RAO, in an RAO when we see, we want the catheter lying posteriorly, right? So it's in the posterior inferior part, this
So you
area.
have to come really septal for fascicular VT.
And very important to be septal. So in LAO, in LAO, see your catheter will tend, when you come through the aorta, catheter tends to go like this to the free wall, right? So you have to, if you have a bidirectional and your catheter is pointing like this, you can just deflect the other way, right? It will come this way. If you have a unidirectional, you have to rotate it and then flex so that you get this contact. So if you have 3D or fluoro, if you have fluoro, you go to LAO, or on 3D, you keep an LAO view, see that you come this side. And as soon as you come this side, you'll record pre-systolic potentials. You'll record the Purkinje potential. So that's a good sign that you're in good contact with the septum. And then once you're in the septum, you can map a little bit apical posterior to see which is the critical part in this.
Yeah, you'll have to pull back and clock torque it so it comes in contact.
Yeah. RVOT?
RVOT left main injury.
Yeah, so let's see. So like we said, see the aortic root is most central, so it's very difficult to see. Okay, fine. But basically this is the aortic root, and so the aortic valve is somewhere here where my finger is, And now if you go into the RVOT from here, so you can see here, right? So this is, you have the two facing sinuses, so the left and right. So the right will come here, more atrial, but then the left here. So if you're in the RVOT here, in the posterior, posteroseptal RVOT, what we call, some of the more common arrhythmias, you're actually in fairly close relationship. That's what I said. Like depending on the height and at which you are, close relationship to both the RCC and the LCC also. So you can be close to the left main.
Anterior RVOT there is no risk. Anterior RVOT.
Anterior RVOT, the main, the free walls are.
Anteroseptal, if you are like here we are ablating, this spot is.
Yeah.
Okay, that is okay.
Yeah, so that becomes free wall. Yeah. So once you're free wall, then only risk of rupture and those things.
We are ablating the pulmonary wall in this left pulmonary wall.
Yeah.
It is very close to the left.
Left main.
So posterior side. Anterior side also.
Yeah, anterior becomes free wall actually. Yeah, only posterior part of the septum. All right. So thank you everyone. We'll move on to the next session.
Thank you so much, Dr. Raja Selvaraj, for such a wonderful anatomy session. Can we all have a big round of applause for this session, because it was indeed a very enriching and wonderful, as I said. Now we will move on to the next session, which is the potpourri, and for this I would like to invite on stage the chairpersons, Dr. Ashish Nabad and Dr. John Roshan. A warm welcome to both of you on stage, sir. And would also like to invite the first speaker, Dr. Praloy Chakraborty. May I please request the honorable doctors to please come up on stage, and let us begin with the next session. I once again welcome the chairpersons, Dr. Ashish Nabad and Dr. John Roshan on stage. Welcome, sir, and our first speaker, Dr. Praloy Chakraborty.
There's still some learning left to do. Good morning, everybody. Last day of the Ihrscon. We are in the Dr. Juneja Hall and Dr. Mohan Nair Hall, sorry. And there is still some learning, nice topics in this session, I see. So let's, without much wasting any time, get on with the first talk.
Thank you, respected chairpersons. Thank you, everyone. Yesterday, when I couldn't make it due to time constraint, I was very happy. I thought that will be my fun trip to Calcutta without any assignment. And today I was planning to get my favorite Calcutta biryani in a good restaurant. And I also thought that, after 2 days, massive clinical presentations, people will not digest my things. But Sujit forced me to do it. And if you don't like it, just blame Sujit. So thank you. I have nothing to disclose. One famous French playwright, Molière, once said, "The mind has great influence over the body, and melodies often have their origin there." He was perfectly right. Now we understand that a lot of cardiovascular diseases, they result from the abnormality of the brain-heart axis. But fortunately, we have learned some technique to modulate it. So yesterday, day before yesterday, Dr. Namudri actually discussed in detail the autonomic nervous system of autonomic anatomy of the cardiovascular system. I'll just give a small insight. So brain is connected to the heart through the extrinsic autonomic cardiac nervous system. The extrinsic system consists of the parasympathetic component and the sympathetic component. The parasympathetic component is formed by the vagus nerve, which principally carries the efferent fiber and efferent preganglionic parasympathetic fibers, and the sympathetic component consists of the preganglionic sympathetic fibers, autonomic sympathetic ganglia, and the postganglionic sympathetic fibers. And these nerves terminates in the intrinsic cardiac autonomic nervous system, which is also known as a little brain within the heart, and they mainly consist of the interneurons, the terminal neurons, and the neurons, small neurons, which originate and they terminate on the intersurface of the heart. So, the intrinsic autonomic cardiac nervous system, that is basically arranged as autonomic ganglia, and interestingly, atrium has the richest autonomic ganglionic innervations, and those autonomic ganglia are mainly located around the pulmonary veins, which plays a crucial role in the pathogenesis of atrial fibrillations. So, this autonomic cardiac nervous system plays a role in cardiac metabolism, membrane electrophysiology, calcium dynamics, mechanical functions, inflammation, myocyte growth and survival, and in maintenance of the vascular tone. So, these are the neuroscience-based techniques, interventions which are used in cardiovascular diseases. So, if we see, there are lots of techniques, and we know few techniques are commonly used, like stellate ganglion block. Physiologically, these techniques can be divided into three groups. The left-sided group, they are mainly associated with sympatholytic effect. The ganglionic plexus ablation is associated with parasympatholytic effect, and vagal nerve stimulation and lower level carotid body stimulation, they are associated with a combination of sympatholytic and parasympathomimetic effect. So, coming to the vagal nerve stimulation, it can be invasive through cervically implanted vagal nerve stimulation or IVNS. IVNS is actually pretty old procedures. For last 90 years, it's being used for refractory epilepsy. The transcutaneous cervical vagal nerve stimulation is through a device which is placed on the neck, and the transcutaneous auricular vagal nerve stimulation, which we are going to discuss in detail, and another is percutaneous auricular vagal nerve stimulation. The transcutaneous auricular VNS and transcutaneous cervical VNS are non-invasive. So, actually, what is it? The transcutaneous auricular vagal nerve stimulation targets a specific area of the ear, that is basically the pink area, the part of the external ears, including the cymba conchae and the tragus. And this area is selectively supplied by the auricular branch of the vagus, and this is a pure efferent vagal fiber. And the techniques have been evolved, the different devices have been used to stimulate that area. Currently, we are using this device, and when we put this is the small device and connected to this, and when we put it here, the stimulator here to the tragus, it's the active stimulation, and when we put here, it's a SAM stimulation. And the parameters are like that. This is the parameter which is commonly used in different clinical and animal trial. One thing we call it low-level vagal nerve stimulation. Why it call it low-level vagal nerve stimulation? We all know when we stimulate the vagus, it causes bradycardia. But if we stimulate the vagus with an intensity that is lower than the bradycardia threshold, that doesn't cause bradycardia. So that's why here where we stimulate the vagus, but it doesn't cause bradycardia. That's why it's called low-level vagal nerve stimulations. And the bradycardia threshold usually correlates with the discomfort threshold. So usually we put the intensity 1 milliampere below the discomfort threshold. So how it works? So this is the pathway. When we stimulate this area, the impulse is carried out by the auricular branch of the vagus to the nucleus tractus solitarius, which is the sensory nucleus of the vagus, and then it sends several inputs, and some of the inputs responsible for parasympathetic effect, parasympathomimetic, some of the and sympatholytic effect. And importantly, the parasympathetic effect on spleen actually creates an anti-inflammatory effect. So, TVNS is actually associated with structural changes in the stellate ganglion like apoptosis, increased fibrosis. It is associated with reduced GP activity, and in healthy volunteers it's also shown to reduce the muscle sympathetic nerve activity. And when we when we see the effect on heart rate variability, is actually increases the high frequency component and reduces the low frequency component, indicating a sympatholytic and parasympathomimetic effect. So this is the anti-inflammatory effect that is basically mediated by the effects on splenic macrophage of the parasympathetic system. And interestingly, this effect is mediated by alpha-7 nicotinic cholinergic receptor. This is the metabolic effect. This is actually area of my interest. We all know that structural changes in heart failure and atrial fibrillation, they are associated with extensive structural remodeling. That is that before that we have electrophysiological remodeling, we have contractile remodeling, and we have structural remodeling. But there are two remodeling which precedes the onset of these two. There is one is metabolic remodeling, that means abnormal cardiac metabolism, and the autonomic remodeling. We don't know which happens first among these, but these two actually happens before it. And there is an interaction between the autonomic and metabolic remodeling. In short, the parasympathetic nervous system has a metaboloprotective effect, where a chronic sympathetic excess is associated with a detrimental effect on the cardiac metabolism. So this is a study actually we did on a HFF model of animal model, and we showed that we saw it's a transcriptomic based study, and we showed that if the heart failure, HFF is basically associated with abnormal expression of the metabolically important genes, and if we do LLTS for 2 weeks, actually those expressions are almost normalized, and the main effect is on the mitochondrial oxidative phosphorylation system. So in short, it's improve the mitochondrial oxidative phosphorylation. So these are the physiological effects: sympatholytic, parasympathomimetic, anti-inflammatory, and the effect on the cardiac metabolism. So now let's see what is the effect on different disorders. So atrial fibrillation, we all know that it is associated with increased ganglionic plexus activity, and previous studies in our center and different other centers showed that if you do low-level vagal stimulation, it is associated with reduced activity of the ganglionic plexus, and it also reduces the AF inducibility. This is the study from our center which showed that if you do a 6 months duration, 1 hour daily tracheal stimulation, it is associated with significant reduction of the atrial fibrillation burden and the duration of each episodes of the atrial fibrillation, and is also associated with reductions of the inflammatory markers like TNF-alpha. Next, coming to POTS. POTS is excessive orthostatic tachycardia in response to standing. It usually affects the young female, and the effect of the comorbidity of the POTS is beyond it's beyond the orthostatic tachycardia. They have so many things, and those young female, because of the comorbidities, the productivity of that young age group is severely lost. And we have limited treatment option for POTS. Yesterday, Dr. Satish Raj was discussing all those things. It was found that people who have received vagal stimulation, non-invasive or invasive for other indications, a meta-search showed that it is associated with reduction of the orthostatic tachycardia and an increase in the tilt time. That means the orthostatic tolerance is increased. Then we developed an animal model of POTS, and I showed that, I'm not showing all those things, we showed that the TVNS is actually modulating the pathophysiology of POTS, and this is a clinical study. We showed that 2 months duration 1 hour daily TVNS in POTS patient is associated with significant reduction of the orthostatic tachycardia, and it is also reduces the low frequency component of and it also increases the high frequency component, and it also reduces the inflammatory markers levels. So this is I'm showing the mechanisms. What are the possible mechanism how TVNS can modulate the broader spectrum symptoms in POTS, not only the orthostatic tachycardia, also the other symptoms. Last is in heart failure, in an animal model of heart failure. Again, the HFF model, TVNS was associated with significant reduction in inflammatory cell infiltrate and fibrosis. It was associated with significant reduction in the inflammatory markers, and it was associated with significant improvement of the diastolic function. It was also, and we saw that olmesartan doesn't change anything, but if we add some alpha 7 nicotinic cholinergic receptor block, it actually the effect is gone. So that means it is mediated by the specific receptors. So this is a clinical study that showed that for 3 months duration, 1 hour daily, TVNS is associated with significant improvement in the diastolic functions and reduction in the inflammatory level. And importantly, there is a correlation between the GLS and the inflammatory cytokine level. So it shows that some of the effect may be due to the anti-inflammatory effect. This is a study on the acute decompensated heart failure patients who are hospitalized, and we showed that if we do during the hospitalization, this is an extensive 8-hour daily TVNS that is associated with significant reductions in the oxidative stress as well as the inflammatory levels. So the questions remain unanswered. What will be the optimal dose? You know, this is a bioelectric therapy. It is not like a pharmacological therapy, not a single dose. We have different parameters. How those parameters, that is still known, and we have developed some of the parameters through previous trial, and we are using repeatedly that thing, but we don't know what should be the parameters, what will be the optimal duration. We have to look for that. And which subsets of patients? It's the early onset heart failure or late onset heart failure. We still don't know that when to start the therapy. Third thing is that we need some biomarker to see the effect, you know, but there is no biomarker still now, and we are trying to develop some biomarkers. Recently, we have come up with some data whether protein kinase A, we can estimate the serum protein kinase A activity, which can be a biomarker. So these are the things still need to be done. We need a big trial to prove our concept. So to conclude, TVNS is an attractive non-pharmacological strategy. It's safe. Preclinical and clinical data are encouraging. Additional cholinomyopathic action might add incremental value, and large clinical trials are required to establish the efficacy, selection of appropriate patient population, and optimal dosing parameters. I am thankful to my team who helped me a lot to develop few of the concepts and to complete the studies. Thank you.
Thank you very much, Pranay, for giving us a peek into this vagal nerve stimulation. Obviously, there are more questions than answers. Heart failure, sympathetic overactivity is a compensatory response. How do you know the cutoff of what is compensatory and what is overcompensatory?
So, you know, so this was the question. So, if you see some of the papers in 1993 by a very famous guy called John Flores, he actually showed that the sympathetic response, which we used to think that's a compensatory in heart failure, the sympathetic overdrive happens way before the onset of the heart failure. So there are some data that sympathetic overdrive, insulin resistance, those things happens before the onset of the heart failure, and it is exacerbated after the hemodynamic decompensation. Yeah.
And there was no mention of using this to curb the risk of sudden cardiac death. So do you have
studies are going on, and there are some studies that show that the patients with myocardial infarction, when they're admitted in the ICU, if you do that, that can increase that can improve the myocardial recovery and some of the arrhythmia. But those are very small studies, you know.
questions from the floor? Very new topic, yeah.
Thank you, Pralay. Very nice talk. And it's amazing how many effects you can have from just stimulating a vagus nerve from externally like this. So I had two questions. One is, it has a lot of pleiotropic effects affecting multiple organ systems. So is there any possible, adverse effects to chronic low-level tragus nerve stimulation? That is one. And another is, considering what beneficial effects it could have in different subsets, like we discussed, heart failure, atrial fibrillation, and probably even sudden death. How do you see this would this be developed as a device in the future which patients can use? Will it be a miniaturized stimulator they carry and they plug it in for 1 hour every day? Or how do you see it being developed
for patient use.
Yeah. So coming to your second question first, so actually the device is very small. It's smaller than a cell phone. So patient can carry it. And we still don't know that whether morning stimulation or evening stimulation, there's a difference because, sympathetic tone differs in different time. And coming to your first questions, the initial things are very promising, but the problem with heart failure and atrial fibrillation, I find that, we have to find some stage of the disease which is actually early stage, and after a certain stage, if you can do anything, you cannot reverse the remodeling, So that is we still find, we have to find, and for that we need some parameters, some biomarkers. And another thing I can tell you, so we try to see that the heart failure who have recovered and the end stage heart failure, what's the difference between the autonomic parameters like heart rate variability parameters, And we need some novel parameters to identify that reversible stage. So normal, reversible, irreversible, we still need something. And another thing, we don't have any parameters, even the heart rate variability, they actually reflect. So if we think that they reflect the role of autonomic nervous system on the sinus node, not the ventricle. So that's why we are working that we need something ventricular parameters for the autonomic tone that can tell us. So we are working on some biochemical parameters like protein kinase A as well as some ECG parameters. Yeah.
One question. Do we have any information on left versus right versus bilateral?
Yeah, that's a very good question. So actually the effect is always bilateral. They have done left versus right and bilateral. There are some studies. But the effect is, if one side you have the same effect. So initially when these things came, the vagus nerve, invasive vagus nerve stimulation, they always put it in the right. Because they used to think that in the left, because they used to think that in the right side it will affect the sinus node and all those things. So conventionally the invasive for epilepsy they put it in the left side. But for for the non-invasive there are some studies. And that showed that actually from our center previously some animal studies, they showed that there is no difference. But if you cut the vagus nerve on one side, then it affects because the vagus nerve also carries the efferent fibers and efferent fibers both. So that happens. But until both the vagus is intact, so that's why we don't provide it to the vagotomy patients,
So with your light of your information that you have, what is your stake on the patients who undergo cardioneural ablation on the long term? What do you expect them to have?
So so I have shown here that how much the parasympathetic tone is important for heart. So what are you doing in cardioneural ablation? So just don't look at anything. Just see at the heart rate. The last study showed that you increase the heart rate minimally by 12. The mean heart rate is increased by 12, And the UK biobank study showed that an increase in the heart rate by 10 is associated with 15 to 20% increased in cardiovascular disease and mortality. So first thing that, and second thing that just young patients, you are increasing the sympathetic drive, you are creating a state of iatrogenic sympathetic excess. Think of the future impact. Actually, there is a study from Dr. Shiv Kumar Center that was on the dog model, and they showed that actually CNA increases the ventricular arrhythmia vulnerability in this patients, specifically in presence of ischemia.
Hello, sir. I have a question for you, sir. Yeah. So I had a patient of 30 years old female. For obesity, she underwent gastrectomy. Post-gastrectomy, she had inappropriate sinus tachycardia. Even on the Holter also, her heart rate used to be between 110 to 130. And that episodes are also, during daytime, she is having that palpitations more. She is not tolerating ivabradine. Have you come across any case post-gastrectomy having inappropriate sinus tachycardia?
Inappropriate sinus tachycardia, what's the age?
30, sir.
Yeah, it's common. I don't know whether it's related to post-gastrectomy or not, but inappropriate sinus, specifically after any surgery, any surgical stress, it's common because after any surgical stress, you have some mild increase in the cytokines level also, and those cytokines they actually augment the response of the sympathetic system, sympathetic catecholamines on the sinus node. So it's common.
It's already been 2 years, sir. Post surgery.
Yeah, and once it's precipitated, that's a vicious cycle.
Thank you, sir.
Yeah.
Thanks, Pralay. I think you will be happy that Suchit rescheduled you today morning. A lot of questions. And you have one more to go. Sure.
Another more, Yeah, can you show it? So this is another topic. Again, no disclosure. So, AICD has reduced the sudden cardiac death and all the high-risk patients, then it's AICD. But we need something to suppress the ventricular arrhythmia. And I know radiofrequency ablation is an attractive strategy. It is effective, but there are some limitations of radiofrequency ablations. So medical therapy is still the mainstay to suppress ventricular arrhythmia in those patients, and specifically and it's very challenging to have a good pharmacological strategy for patients with structural heart disease. So in patients with structural heart disease, we all know that the principal mechanism of ventricular arrhythmia is re-entry. And what we are trying actually by pharmacological strategy is just to abolish this excitable gap so that the head meets the tail and the tachycardia terminates. So what the current pharmacology strategy says. So you have to increase the wavelength, and wavelength equal to conduction velocity and effective refractive period. And you can increase, there is no way to increase the conduction velocity, so you have to increase the effective refractive period. That can be done by two things. Either you prolong the action potential duration that correlates with the refractive period, or you block the sodium channels so that something called, just like the phenomenon of post-eporesis refractoriness, your action potential duration is not prolonged, but the sodium channel will not recover, so it will increase the refractive period. But the problem is that the current pharmacotherapeutic agents, they have detrimental effect, specifically in patients with structural heart disease where the borderline hemodynamics. The first is the negative effects on the cardiac hemodynamics, so they can cause hypotension. Extra cardiac toxicities we all know, and we all discuss about that. But the most dangerous is the proarrhythmia. Class 3 agents, when they prolong the action potential duration, they can cause malignant torsions. And for class 1 agents, so we are trying to block the sodium channels. But at the same time, if you block the sodium channels, you will decrease the conduction velocity. If you decrease the conduction velocity, your wavelength is reduced, and the excitable gap will be increased. So it can precipitate actually insufficient arrhythmia, which is most evident with class 1C agent because of their very slow dissociation kinetics. So we need something, So there are a few ways to look at how can we do it. So first is intracellular calcium signaling by modulating, whether we can do this. Second and third, if I have time, I will discuss, other will not discuss. So coming to the calcium, when the action potential reaches a specific point, it's a very simple picture, a specific point of the cell membrane. When it's depolarized, it activates the calcium channel, L type of the calcium channels, and some calcium enters from outside the cell inside the cells, and that minimal calcium actually induces a massive release of calcium from the sarcoplasmic reticular store. That's called calcium-induced calcium release, and ultimately during the diastole, that calcium is taken up by the sarcoplasmic sarca ATPase. It's an active calcium transport system. And the calcium is important for so many things. It modulates the contraction. It's important for mitochondrial biogenesis and oxidative phosphorylations. It controls the structural remodeling like apoptosis and fibrosis. At the same time, it controls the membrane voltage. So there are several currents which are dependent on calcium, and thus it can control the membrane voltage also. So then what are the targets? So we have two things. One is ROIR2 or cardial ryanodine channels, and another is the SARCA. So ROIR2 can be modified by the genetics. We all know that ROIR2 gain of function causes CPVT and loss of function causes calcium release deficiency syndrome or CRDS. The expression can be increased or decreased. That happens in structural heart diseases. Associated proteins like calcioequestrine, FKBP, like FKB12.6, triadine and calmodulin, all those proteins actually they control, and their mutations we know that they are associated with something like CPVT or calmodulinopathies. Metabolic intermediates also control the activity of ryanodines, and post-translational modification, that is most important, because that is most important in the acquired heart diseases. And the common is phosphorylation, and other things are like oxidation, and all those things also happen. For SARCA, it's expression, and energetics, it's an active pump, so energetics plays an important role in controlling ATP level and the post-translational modification. So this is the normal calcium signaling. If you see that the rise is very fast, the fall is very fast, the amplitude is good, and there is the bit-to-bit alteration between the amplitude is very less. This is the dysregulated calcium signaling. The slope is slow, the amplitude is slow, the fall is slow, and sometimes we have diastolic calcium overload. And the bit-to-bit variability, that's also called the calcium alternance, that is high. And it has been found that that slow amplitude and slow rise that causes decreased conduction, the slow fall associated with diastolic dysfunction, and this high diastolic calcium and the alternance causes arrhythmogenesis. So this is the most extensively studied, the ryanodine receptor modulation. Others are just in the experimental level, and metabolic modulation is different thing. So it has been shown that in ischemic ventricular fibrillation is associated with an increase in the diastolic calcium as well as increase in the calcium alternance. And dantrolene, which is a skeletal muscle relaxant agent, which is basically a skeletal muscle ryanodine receptor activator, it's a modulator. It also modulates the ROIR2, and that actually reduces the diastolic calcium and improve the calcium alternance. And that leads to VF recurrence and improve the post-resuscitation hemodynamics in an experimental model. It's a pig model, and that showed that. Second thing is ryanodine receptor doesn't change. That pure ryanodine receptor modulator, they don't change the action potential duration or the action potential upstroke. What it means? So we all know that the class 1 antiarrhythmic agents is associated with the slowing of the action potential upstroke. That actually causes slow conduction velocity and proarrhythmic. On the other hand, the class 3 agents are associated with APD prolongation that causes torsades. But these ryanodine channel modulators, they don't prolong the action potential, or they don't reduce the slope of these things. Another thing is that other than the action potential durations, the most important, what is the heterogeneity? Action potential heterogeneity and action potential upstroke heterogeneity. Those both things are actually reduced by the ryanodine modulators. And some of the things like class 3 agents, they actually increases the action potential heterogeneity. And mechanical function, so it actually, the ryanodine channel modulator, they reduces they make the slope more stiff. So this is associated with improvement of the systolic and diastolic function. It has been found in experimental model of acute as well as chronic cardiomyopathy that dantrolene or its derivative is associated with improved systolic and diastolic functions. So this is the study in explanted human heart, like, which are explanted for advanced heart failure, and it showed that it doesn't change the systolic or diastolic function. So that is, we don't expect that at end stage heart failure, the contractility is not only dependent on the calcium, it's also extensive fibrosis. So we didn't expect any improvement, but at least it doesn't do any harm to the heart. So there is a concept. So how it happens? So now come to single ryanodine channels. So a single ryanodine channel is releases one calcium, and then it is taken up by the SARCA. So what it creates? It creates for each single ryanodine channels there's a calcium spark. This is called calcium spark. Now when we integrate this concept in a plate of ryanodine channels which are activating almost simultaneously. So then your global calcium transit, this is more efficient, But at the same time, what happens in the cardiomyopathic process, the opening is very desynchronized. So they are activated in different time. So that causes the dysregulated calcium transient. So this is and ryanodine channel modulators actually reverses is synchronize the calcium channels. So and we can measure the calcium release synchrony. This is in single cell confocal microscopy, and this is in a whole heart model. We measure and we validated the calcium synchrony measurement parameters. And actually, if you reverse the calcium synchrony, if you desynchrony, if you synchronize the calcium release, simultaneously you can improve the contraction as well as reduce the arrhythmia. So these are the ryanodine channel modulators available. So with sodium channel blocking action, flecainide, hydrogen molecules, without sodium, the pure iodine receptor blocker, dantrolene and azmoline, and with sodium channel blocking actions is phenytoin. Azmoline is actually not clinically available if it's an experimental drug. An advantage of azmoline is it's water soluble, and dantrolene is very lipid soluble. So, you know, when you're doing an experiment, it's very difficult to get it dissolved in the perfusate. So we use azmoline for the Langendorf studies. So you all know that flecainide is associated with reduced diastolic calcium load and calcium abnormalities in CPVT, and that has been translated into improvement in the ventricular arrhythmia events. And CPVT now, flecainide is a standard drug, and it's a first line of drug. Flecainide has also been used to suppress the atypical triggers in patients with like, you know, KCNG2 mutations. It works very good. But the problem with flecainide is the sodium channel block with a very, what I can tell, slow dissociation kinetics. That is responsible for the proarrhythmias in presence of structural heart disease. Second is phenytoin. Phenytoin is an excellent drug. Other than it has multiple effects. You know, it stabilizes the ryanodine channels. It also has blocks the lead sodium channels, and it also blocks the LTCC. So it reduces the action potential duration also. So that's a very good effect, and that can be used in some of the difficult conditions like calmoduloneuropathy. It can be very effective. So ryanodine receptor modulations with dantrolene. Dantrolene is being used for long durations for skeletal muscle disorders, and its cardiac safety is established. And dantrolene is in some clinical studies, they have also used dantrolene in CPVT, and that showed that dantrolene is associated with reductions of the stress-induced VTs in CPVT. And this is a study which is evaluating the role of dantrolene in heart failure on arrhythmia as well as mechanical function. And this study can tell us a lot. So metabolism, cardiac metabolism can modulate the calcium signal through multiple things, and we all know that SGLT2 inhibitors are associated with improvement of the mechanical function as well as reduction of arrhythmia, ventricular arrhythmia. And this is a study which actually showed that SGLT2 inhibitor actually it improves the metabolic functions, and thus that's why it causes this. And there's another molecule is AMPK. AMPK is a very interesting molecule. It's a metabolic stress sensor molecule which is activated when the cell is metabolically challenged. It balances the metabolism. And we saw that actually calcium dysregulation is associated in some of the ventricular arrhythmias like Bruton tyrosine kinase induced cardiomyopathy. And there is a correlation between the AMPK phosphorylation and V inducibility, and we can improve the AMPK. If we activate the AMPK, we can reduce the abnormalities. So this is TRPM. This is another ion channel. This is calcium activated non-selective cation channels, and it's not permeable to calcium. So there is some data that if you use 9-phenolthal in Purkinje fibers or in ventricular muscle structures, muscles in ischemia deperfusion model, you can reduce the action potential duration as well as you can suppress the things. And we did a study in non-ischemic cardiomyopathy. We showed that it doesn't change the calcium dynamics, but the problem is that TRPM4 modulation is associated with increased in the APD alternance as well as reduction of the conduction velocity, and it also reduces the VF dominant frequency. So the problem is that it has multiple, it's not a pure TRPM inhibitor, so we still don't know why it's happening. Most probably it has sodium channel blocking effect also. Funny current and late sodium current inhibitions are the other strategies. So to conclude, there is an unmet need for a novel alternate strategy. Ryanodine receptor modulation is mechanistically unique. Dantrolene is clinically available and safe. Long-term benefits of dantrolene needs validation by prospective clinical trial. Combination of QT shortening and ROI2 stabilization by phenytoin may be useful in some difficult situations like calmoduloneuropathies. Phenytoin inhibition by ivabradine may be particularly used in heart failure patients. As a strategy, TRPM inhibition and late sodium current inhibitions are attractive, but we need some better agents. So all my works are dedicated to the animals who are sacrificed for my study, and I am thankful to my amazing team. Thank you.
Thanks. Any questions from the floor? Can you make some comments on the effect of cordron and amiodarone and dronedarone on the calcium channel handling, or they have negligible?
The problem is, amiodarone is it has multiple effects. So it's very difficult to identify single effect. So that's the problem. But amiodarone has effect on sodium channels, it has effect on calcium channels, it has effect on potassium channels, so it's a multi-channel.
Is dronedarone worse in terms of its pro-arrhythmogenic risk?
It's the studies in heart failure so that it increases the arrhythmia. But I think with dronedarone there was a lot of basic studies to evaluate those things. So.
Sure. Thanks. Thanks, Pralay. Both interesting.
Yeah, dantrolene is on pipeline. And dantrolene is on pipeline, yeah. We are preparing a specific preparation and we are planning for a study for dantrolene also.
Thanks, Pralay. Great presentations.
Now invite our next speaker, Dr. Vijay Shekhar.
A very good morning to respected chairperson, senior colleagues, and my dear friends. At the outset, I'd like to thank the IHRS organizers for this opportunity. So, my topic will be on SVT management during pregnancy. So, as always, pregnancy becomes a challenge when we encounter with arrhythmias, possibly because of the unique and peculiar mechanisms attached to it. And any disorder with pregnancy, always there are two lives at stake. So, all therapeutic decisions are taken into consideration with maternal and fetal risks taken into account. Again, conventional treatment options like drug therapy and radio frequency ablation have their own disadvantages when done in pregnant patients, and so we'll discuss those things. Generally SVTs are considered benign, but large-scale studies have shown that there is an increased maternal as well as fetal risk in the form of low birth weight and preterm. And so the arrhythmia can be a completely de novo arrhythmia, or sometimes a patient with the pre-existing arrhythmia has a 20% risk of exacerbation during pregnancy. And the situation becomes even more complex when there is an underlying congenital heart disease or a structural heart disease that has not been attended previously. So these are mechanisms that are very much unique to and peculiar to pregnant patients. So one is the increased plasma volume that itself causes a mechanical stretch. And again, the influence of catecholamines, the chronotropic effects of relaxin, the vasodilatory effects of estrogen, all sum up to promote arrhythmogenesis in pregnancy. So I'll start with a case. So this is a 24-year-old female, a preemie. There is a past history of surgical ASD closure in childhood. No prior documented tachycardia or palpitations. She presents for the first time at 32 weeks of gestation. So this patient was initially treated at a different center, diagnosed to have a narrow complex tachycardia, and then adenosine was administered, no response. Then with beta blockers, she developed hypotension and so was referred. At the time of presentation, her blood pressures were kind of borderline, systolic BP around 80 to 90. And then the EF was also low, the around 40-45%, probably as a result of tachymyopathy. A quick assessment of the fetus showed that the CTG was normal, so fetal well-being was assured. So in this patient, there is an immediate need to establish, to restore sinus rhythm in this patient. Otherwise, there is a risk that this patient might develop or a fetal distress or a maternal compromise as well. So the best option we have in this patient, because already drugs have been tried, is to cardiovert the patient. So the patient underwent a cardioversion. And while attempting cardioversion in pregnancy, it is no different from what we do in non-pregnant patients. The position of the patches and the energy is all the same. Only thing is, when we do it later, during the later part of pregnancy, there is a risk that the shock itself can trigger uterine contractions and a preterm labor. So always the OBG team, the obstetric team has to be alerted. In case there is a need for an emergency LSCS, the patient has to be taken up. So that is what we did, but luckily for us, the patient did well with cardioversion, and the fetal well-being was also assessed post-cardioversion, which was good. In either case, I mean, if this patient was hemodynamically stable or not in this patient, the hemodynamically stable SVT will receive the same treatment as a non-pregnant patient, vagal maneuvers, adenosine at the same dose. And when we are administering the second line drugs, that is beta blockers and calcium channel blockers, one should be very aware of maternal hypotension that can be associated with these drugs. Again, a word of caution about amiodarone. Amiodarone is not indicated in pregnancy, but there are again some case series and reports where amiodarone has been successfully used to treat these SVTs in very refractory patients. But again, they have to be used as a very last resort after explaining the risks to the patient. So this is again just summing up the same thing, so I don't want to go into the details of it. So this patient after cardioversion, so there is evidence of, ASD on the ECG. There is an RSR- pattern with an RV strain, and the P wave is also abnormal, indicating that there is a diseased atrium. So what next? So what therapy? This patient has presented at around 30 weeks of gestation. So what do we do next in this patient? So when we consider chronic therapy, there are a lot of factors that we usually take into account before deciding what to do next. In this patient, there is a surgical scar. Probably going by the arrhythmia nature, it will be a macro-reentrant AT, and this is the first episode of the patient. So what we decided was to put the patient on drugs and continue the pregnancy up to term, and then probably plan an elective radiofrequency ablation later on in the postpartum period. So the patient was started on flecainide and beta blockers. She did well, and she completed her pregnancy without further any arrhythmias or any events. So when we think of drugs, usually the first line antiarrhythmic drugs that we commonly give in pregnancy are beta blockers. Metoprolol and propranolol are the usual preferred drugs. And when one administers metoprolol during the second and third trimester, we should be aware that we should increase the frequency of dosing of metoprolol because of the kinetics of the drug. Again, calcium channel blockers, there is a slightly higher incidence of low birth weight and preterm, and digoxin has good safety profile being used in pregnancy. A word of caution for atenolol among the beta blockers, it should be avoided because of the increased risk of associated IUGR because of its plasma protein binding properties. And when the first line therapy fails, we resort to the second line drugs. Most often what is available to us is the class 1C drug flecainide, and then the class 3 drug sotalol. Both these drugs have been known to be associated with very less fetal adverse effects, but again, not to mention the proarrhythmic effects that have to be monitored. When patient is on sotalol, QT interval should be monitored, and flecainide QRS intervals. Otherwise, they are relatively safe. In fact, both these drugs can be used to treat fetal arrhythmias as well. So moving on to the second patient. So this is a 28-year-old female, 30 weeks, again incessant tachycardia. This patient, you can see that there is a long RP, regular narrow QRS tachycardia, and the spontaneous initiation and termination suggests probably we are dealing with an atrial tachycardia. And so adenosine was administered in this patient, just confirming that it is an atrial tachycardia. There is an AV block, brings out the P waves. And again, this tachycardia is not responding to the first line agents as well. So unlike in the previous patient, where the LV was down, the patient had very borderline hemodynamics. Here, the LV function was good, maternal hemodynamics were good, and the CTG to assess the fetal well-being was also good. So now there is no urgent need to establish sinus rhythm in this patient. So we put her on drugs. We started her on sotalol, uptitrated it, and then within 24 to 48 hours, she was, she reverted to sinus. And then again the same story, we completed the pregnancy with the drugs, and then she underwent an RFA 6 months later because she had one or two breakthrough episodes, and this was, tachycardia, atrial tachycardia from the inferior aspect of the tricuspid annulus that was successfully mapped and ablated. So the first line therapy is always beta blockers, digoxin, and then once it fails, sotalol and flecainide came to the rescue. Both these drugs have been found to be very effective and like in our patients, but sometimes when drug therapy fails, then what are we left with is catheter ablation. So when it comes to radio frequency ablation, it is as much as possible we try to defer it during the postpartum period and plan it electively. The reason is not only the radiation risk associated with the the ablation, because we have now techniques to do it zero fluoroscopy or minimal fluoroscopy. But there are again, and the amount of radiation the patient will receive during an ablation is far less to the permissible limit of radiation that is required to produce a fetal adverse event. It is around only 1 milligrays compared to 50 milligrays. But then there are some non-dose related effects, stochastic effects that have been reported. That is a small incidence of childhood cancers. And again, the procedure itself can induce a fetal distress or a preterm labor as well. So if it is for these reasons, it is better to postpone the radiofrequency ablation to a later date and as much as possible manage with drugs unless the patient is in an incessant tachycardiomyopathy or very much drug refractory. So this is zero fluoroscopic ablation. This is not in a pregnant patient, this is a normal patient. It is good to know this technique because sometimes, it can become handy when you really need it. This was done for an AV-NRT ablation. So the last case, so this again term pregnancy, almost 36 weeks, again refractory SVT, not responding to any of these drugs. Again a long RP tachycardia, and in this case again the LV was down, the patient had tachycardiomyopathy, and here the obstetrician said that there is evidence of fetal distress. So now the only measure we can adopt here to save or salvage both the mother and fetus is to go for an emergency LSCS. So with the tachycardia, the patient was taken up for an emergency LSCS. And the anesthesia, we can always have a discussion with the OBG team as well as the anesthesia team. Literature supports the use of epidural anesthesia because that has been associated with the lowest amount of catecholamine release. But whatever the anesthetist is comfortable with, be it GA or spinal, depends on the institutional practice and the individual practice. And once the baby was delivered, immediately the rhythm from 150 it came down to 80. Although it did not revert to sinus, the heart rate dropped. And then this patient was kind of having for a couple of days a multifocal rhythm. The P-wave morphologies kept changing in clusters. So we decided this is not something we have to take up for ablation because of the varying P-wave morphologies. We again put her on drugs, flecainide and beta blockers. And then now 6 weeks, she has, the rhythm is completely sinus, and the LV function has also recovered. So this is our small experience. I'm sure there are going to be more seniors and colleagues with much more experience in treating SVTs in pregnancy. The last 18 months, we have had 7 patients. 3 of them were ATs, a slightly higher prevalence of ATs. Probably could be a referral bias. 2 patients underwent RF, 1 during the prenatal counseling itself and 1 electively post this thing. And none of these patients except for the emergency LSCS patient had any issues during delivery or during thing. And for all medically treated patients, we found that sotalol and flecainide were extremely useful. So just to sum up, so the care starts prior to the delivery itself. So if there is a substrate for arrhythmia, there are risk stratification scores, and try to optimize the drugs or get rid of the substrate for arrhythmia prior to the pregnancy itself. And during pregnancy, we have discussed the strategies what we can adopt. So it doesn't stop here. And again, when we are going to give antiarrhythmic drugs after pregnancy during lactation, again, we have to be choosy about the drugs and also plan the radiofrequency ablation electively. So final thing is a multidisciplinary team, a good obstetrician and an anesthetist makes our work much simpler, and the decision on what treatment will suit which patient will be on a case-to-case basis. Thank you.
Thank you, Vijay.
Thank you, sir.
Any doubts from the house?
Is ivabradine safe in pregnancy?
Sir?
Because most of them are atrial tachycardia.
Yes, sir.
And many of the atrial tachycardia is very responsive to ivabradine.
Ivabradine, actually, the literature says they cannot be used, sir. That is what the literature says.
Vijay, your second case where you use sotalol, you say that the efficacy is equal for flecainide or sotalol, or you would easily use any of those 2 drugs. Now, flecainide has more use dependence and sotalol has more reverse use dependence. So, Why didn't you choose to use flecainide in your second case to terminate the arrhythmia and chose sotalol instead?
Sir, the second patient we used sotalol. So, I mean, we initially started the patient on flecainide, but for some reason the patient did not tolerate the drug well, so then we switched over to sotalol. But even otherwise also we found many patients tolerating sotalol well than flecainide, even when we try to treat them on an outpatient basis. Maybe it is my personal this thing, but also like to know from other colleagues also.
Sir, if you are cardioverting a pregnant lady in unstable arrhythmias, so what about the sedation? Is it propofol or unsedated?
No, we do give mild sedation. I mean, it's again an institutional practice that what kind of sedation needs to be given differs from the, we leave it to the anesthetist to decide what is comfortable for them. Even for the emergency LSCS that we have taken, in fact, I insisted on epidural anesthesia, but the, the anesthetist was more comfortable giving a spinal anesthesia. He said, I'll counteract hypotension if it occurs. I am more comfortable with spinal. So I think it is better to leave it to the anesthetist to decide what drug they are comfortable.
Because most of the sedative drugs are, class C for pregnancy, except for propofol.
Yeah, but I think a short duration of anesthesia does not have much influence. That is what the studies have also shown.
And the amount of the shock is there?
Is it same? Is the same. The position of the patches, paddles are the same. The amount of shock that needs to be delivered is also the same. The only thing is, if you are doing it in a full, gravid uterus, late trimester, there is a risk that it can, the shock itself can provoke a uterine contraction. So that we should be prepared for an emergency LSCS.
Thank you.
Thank you.
Thank you, Vijay, for your talk. We now invite Dr. Bhim Shankar to come and give us his talk on tachycardiomyopathy.
Thank you, Chairperson, sir. Morning, everyone. The task assigned to me is to go over tachycardiomyopathy. All of us know that tachycardiomyopathy, or acronym TICM, is essentially reversible valve dysfunction due to high ventricular rate, whatever the origin of tachycardia is. Although this was supposed to be case-based, I took the liberty to go over some red flags, unsettled issues, the evolving concepts, and then some overlap syndromes like arrhythmia. Now the connotation is different, arrhythmia-induced cardiomyopathy versus tachycardia-induced cardiomyopathy, and I'll finish off with some case vignettes. Although this term tachycardiomyopathy was coined sometime middle of last century, but the concept or the phenomenon how fast ventricular rate can cause LV dysfunction was published way back in 1913 by Braxton Hicks, and then on there were several reports of AFib with fast ventricular rate that can cause LV dysfunction, reversible LV dysfunction. The pure form of tachycardiomyopathy caused by incessant AT or AVRT came in much later part of the century, and this entity got established. For that matter, any arrhythmia that can cause fast ventricular rate can cause tachycardiomyopathy, including VT, idiopathic VTs, flutter with fast ventricular rate, and rarely AV and RT too. It is simply difficult to get the true incidence estimation simply because there is a diagnosis of exclusion, and oftentimes this is going to be variable, the denominator being variable, the incidence that we get from different papers is also very variable. But a ballpark number is like 4% of patients who present with AFib with fast ventricular rate can develop LV dysfunction, reversible LV dysfunction. And in incessant AT, it is about 10%, and for PGRT is the largest number of patients who can present with LV dysfunction. That's about 20 to 50%. The estimates in other conditions are just anecdotal reports, so we don't have the true estimates. But this separate entity, arrhythmia-induced cardiomyopathy, or the PVC cardiomyopathy, in the subset of patients who have more than 10% of PVC burden, about 7% of the patients can develop LV dysfunction. Couple of unsettled issues: how much prolonged should be the tachycardia to cause LV dysfunction, or how many days more? So chronic tachycardia defined as anything lasting more than 3 months. Then again, per day, if they have more than 10 to 15% of the time in a day, can actually result in cardiomyopathy. Is there a precise number, rate in which somebody can develop cardiomyopathy? all the rates, I mean, there's no precise number, but the rates above 100, generally below 150 are thought to be deleted simply for the reason that anybody having rates above 150 would present with palpitation in your clinic, and then there's the chance to develop cardiomyopathy is mitigated. So TAC is rate dependent again if cardiomyopathy. So those patients with higher tachycardia rates would develop TAC earlier. Somebody between 110 and 150, there will be a different in presentation. How about the recovery of tachycardiomyopathy following restoration of sinus rhythm? That's again very variable. It depends on the rate and duration of the responsible arrhythmia. Also, the myocardial alterations will have a bearing on this. Yet another issue that is unsettled is why are some patients prone for tachycardiomyopathy? I'm sure in practice you would have seen patients with atrial tachycardia, incessant AT with the same ventricular rate. Nevertheless, some developing cardiomyopathy early and some not developing. Several variables can have a bearing on that, but there could be also a genetic predisposition. This was found that patients who have, as limited data that found that patients who have gene polymorphism, ACE gene polymorphism have a tendency to develop more tachycardiomyopathy. There's a small subset of patients, 20 patients who had, 40 patients who had incessant AT, 20 who had cardiomyopathy and 20 who did not. The group that had cardiomyopathy was found to have higher deletion insertion gene polymorphism in the AC gene. So this is an editorial dated many years ago, 1985, that highlighted the difficulty in discerning whether the arrhythmia came first or the cardiomyopathy came first. So this difficulty, this dilemma, even now we can have in practice, and it may be difficult to to be certain whether it was cardiomyopathy that was the primary driver or the arrhythmia was the primary driver. Yet another entity is whether it is arrhythmia-induced, meaning pure tachycardia-induced cardiomyopathy versus somebody having a predisposed cardiomyopathy that can be worsened by, exaggerated by the arrhythmia. So that is arrhythmia-mediated. Pathophysiology again is not very well understood. Several research have implicated subclinical ischemia, abnormalities in energy metabolism, oxidative stress, and calcium overload. The translation part is difficult. Dr. Praloy is left. You could have had questions with them. But the pertinent point is all these patients do develop structural abnormalities and ultrastructural abnormalities in the myocardium. And even if sinus rhythm is restored, some of these patients will have their myocardial thinning and LV dimensions enlarged even after the EF improves. This overlap that I was talking to you about is the connotations are different. Earlier, TIC, tachycardiomyopathy and arrhythmia-induced cardiomyopathy are used interchangeably. Now, arrhythmia-induced cardiomyopathy is an umbrella term, and that under that you will have three components. You have tachycardiomyopathy, or you can have frequent VPCs causing cardiomyopathy, which is one component, and the mechanism is not high ventricular rate, but what is implicated is asynergy and post-extrasystolic potential. Similar is the case with atrial fibrillation induced cardiomyopathy, especially once you have controlled the ventricular rate, and despite that if they have cardiomyopathy, then this is AFib cardiomyopathy and not AFib tachycardic cardiomyopathy. How do we manage tachycardiomyopathy? This is, most of us have managed typical incessant ATs in PGRT presenting with tachycardiomyopathy. The strategy should be ablation when it is simpler arrhythmias like atrial tachycardia, atrial flutter, and AV90. Most often it's going to be a combination when it is idiopathic VT or AFib with fast ventricular rate. PVC cardiomyopathy, again, like tachycardiomyopathy, the PVC cardiomyopathy mechanisms are also poorly understood. Autonomic imbalance, LV desynchrony, post-extrasystolic potential, all have been implicated by different researchers. Certain predictable issues about the PVC can let us know whether such patients having some kind of PVCs can develop LV dysfunction on follow-up, like lower electromechanical index, meaning if the number of PVCs that do not produce enough cardiac output are more, then these patients are likely to develop LV dysfunction on follow-up. Epicardial PVC, for simple reasons that it will be wider QRS, they will also cause more asynchrony and therefore cause LV dysfunction on follow-up. The other thing that has been researched on is coupling interval dispersion, or patients who have variable coupling interval PVCs will develop LV dysfunction earlier than patients who don't have that. There was an attempt to create a scoring system, and this was a collaborative paper from San Francisco and Korean group. The derivative cohort on regression analysis found out that there are 4 pointers, and they used a scoring system where the maximum point is 12. Patients who have PVCs which have superior access, they gave points to the percentage of burden in a day, and then the coupling interval. Contrast to what other researchers found that the closer the coupling interval, the risk is high. In their regression analysis, they found that if the coupling interval is longer, the risk of developing LVT is higher. In SVT, of course. So they used this and they found out that patients who have higher ABC-VT score will, in a follow-up of 5 years, are likely to develop LV dysfunction. This has been validated in just one cohort, but may be useful in practice. The same dilemma, whether it is, which is the primary driver, is more seen rather than tachycardia in PVC cardiomyopathy. And a couple of metrics that can help us use is like if they have pre-existing comorbidities, if the echocardiogram shows more segmental hypokinesia rather than global hypokinesia, if there is more scar, it is going to be probably pre-existing cardiomyopathy. The frequency of PVC also, if there is less than 5,000 versus more than 10,000, can help us distinguish whether it is pre-existing, whether the cardiomyopathy is the driver or the PVC is the driver. The PVC pattern, like if it is multifocal versus monomorphic, can also help us distinguish whether it is, which is the primary driver. A word on arrhythmia-induced cardiomyopathy, AFib-induced cardiomyopathy. This is a diagnosis of exclusion after you have controlled the ventricular rate and patients continue to have LV dysfunction. Typically, it is NACM patients with persistent AFib where there is no improvement despite rate control. The best analogy would be patients who were enrolled in camera MRI trial and castle AFib, a subset of patients who had AFib cardiomyopathy who actually responded after AFib ablation. I'll go some case vignettes. Basically, PGRT and ART, incessant AT, we are all familiar, and I'm not going to discuss them here. The critical issue or what facilitates cardiomyopathy in this subset is one is the incessant form and the slower ventricular rate that actually promotes cardiomyopathy. But there is always exception to the rule. I have not encountered patients with non-PGRT AVRT presenting with cardiomyopathy, but again, occasionally some colleagues have encountered. This is a publication in 2021. There are 2 elderly patients who had left lateral pathway, one manifest and one concealed, that were actually 53 and 59, had a heart rate of 180, unlike patients who have insistent, tachycardiomyopathy tend to have lower heart rates and presented with LV dysfunction. For some reason, they were incessant before their presentation, and that could be the reason they developed cardiomyopathy. One other important things to keep in mind is slow atrial tachycardia or atrial tachycardia with 2-to-1 conduction to the ventricle, especially those arising close to the sinus node, like can masquerade as sinus tachycardia, like tachycardia arising around the right superior pulmonary vein, crista, or SVC tachycardia can be passed off as sinus tachycardia. And the one key thing to look at is absence of diurnal variation. That's a clue. Of course, paroxysmal is easy to pick up because the onset will give you the answer. I just put up this publication again from Subjecting Hospital, Dr. Ankit Jain's case, that actually initially was missed off as a sinus tachycardia, and a careful look on the ECG rail, it was shown that the P waves were different in AVL, was inverted, and therefore they mapped and they found that it was SVC tachycardia, and the tachycardiomyopathy settled after ablation. So the key points is any persistent arrhythmia can lead to tachycardiomyopathy. Suspected when there is heart failure and persistent tachy, and it's sometimes difficult to discern the driver. You can look at the temporal history and other parametrics to decide which is the driver. The concept of arrhythmia-induced cardiomyopathy is an umbrella diagnosis, and under that we'll have 3 components. Ablation AID is a strategy, and that is based on the individualizing in each patient. I'll stop there.
Thank you, Beam. Any questions from the house?
Beam, if I have to ask you, are there any early echo predictors of tachycardiomyopathy like the GLS and the strain? And secondly, are there predictors of reversibility of a tachycardiomyopathy before you undertake any
So I think TLS is coming a lot in oncocardiology. I'm not sure if there are papers which are assessed in tachycardiomyopathy. If you have done MRA for other reasons, if they have scar, unlikely that they will reverse even after your arrhythmia is resolved.
Sure. Thanks, Bim.
Sir, 1 minute, sir. A quick information. The faculties, those who have to check out today, are kindly requested to do that before 12 o'clock. I repeat, the faculties and doctors who have to check out today are kindly requested to do the procedures before 12 o'clock. Thank you so much, sir.
Sure, thanks a lot. And we move ahead on this session. Let me invite Dr. R.D. Yadave to give his presentation on long RP tachycardia.
Respected chairperson and dear friends, first of all, I want to thank Dr. Suchit and team who has given me the topic, and this is a day in day out topic of electrophysiologist, what we call bread and butter. So the topic is in long RP tachycardia, how to decipher the devil. So here, long RP tachycardias are an unusual and defined well when RP interval is more than 50% of the RR interval. It includes atrial tachycardia and 4 AV node dependent tachycardia. 4 AV node dependent tachycardias are pure atypical, that is fast slow or slow atrioventricular nodal re-entry tachycardia. Atypical AV NRT with concealed bystander nodoventricular bypass tract inserting to the slow pathway. That is atypical AV NRT with bystander NF, NV, ABP. Orthodomic tachycardia, that is called PJRT, and orthodomic tachycardia using concealed nodoventricular or nodofascicular bypass tract. Fifth is we can use it also as a differential diagnosis, JT with retrograde conduction through the slow pathway. So these are the 4 AV node dependent long RP tachycardias, that is the atypical AV NRT is here, and in the pathway mediated PJRT where atrioventricular connection is there. In NFRT or NVRT, where the ventricular connection or right bundle branch connection to the slow pathway region of the AV node is there, not in the atria. And atypical AV NRT with bystander these are the 4 causes AV node dependent long RP tachycardias. Now, spontaneous clues, when present, clues from the transition zone like initiation of the tachycardia, termination of the tachycardia, AV block, bundle branch block can provide valuable information about the mechanism of the tachycardia. Initiation of tachycardia from ventricle, that is ventricular premature depolarization or ventricular pacing are used against the AT but can be possible. Reproducible cycle length prolongation and termination of the tachycardia with delay and block in the AV node, that is antegrade limb block, indicates AV node dependent tachycardia, that if tachycardia terminates with A without V, that excludes atrial tachycardia. AV node dependent long RP tachycardias often oscillate or terminate in the retrograde limb, not the antegrade limb. So slow pathway or decremental pathway, which is unhelpful in making the diagnosis of the long RP tachycardia. Persistence of tachycardia despite the development of the AV block indicates that the ventricle is not the part of the circuit and eliminates orthodomic re-entry tachycardia. Such a finding is common with atrial tachycardia and rare with atypical AV NRT. Prolongation of the VA interval and tachycardia cycle length with bundle branch block indicates that the His-Purkinje system is an integral part of the tachycardia, that is Kummel's law, and establishes a diagnosis of PJRT or NFRT or NVRT, whatever, ORT. However, bundle branch block induced changes are not always evident with long RP ORT because of septal location of these accessory pathways where we want 20 millisecond or more and their decremental properties which compensates. So acceleration of the rate over the AP due to abrupt loss of bundle branch block ipsilateral to the accessory pathway is counterbalanced by slowing of the AP conduction via prolongation, so that any changes due to bundle branch block can be minor and difficult to appreciate. So while clues from spontaneous transition zones are helpful, they are often absent, and pacing maneuvers are generally required to establish the true diagnosis. So most of the pacing maneuvers, you people are well versed, I just rememorize them. While standard pacing maneuvers used for short RP tachycardias can be applied to AV node dependent long RP tachycardia. They are limited by atypical responses due to decremental properties of the retrograde limb, that is the slow pathway or slow pathway or the retrograde AP of these circuits. So what are the pacing maneuvers? Because identifying retrograde limb, slow pathway or AV atrioventricular pathway, atrioventricular pathway, nodovascular accessory pathway is critical to the diagnosis of AV node dependent long RP tachycardias. So pacing maneuvers delivered during tachycardia like his refractory VPD, entrainment, ventricular entrainment or sometimes atrioventricular entrainment, both entrainment are often more useful than those performed during sinus rhythm like parahygian pacing or differential RV pacing. But the entrainment from the base and apex of the RV may helpful, but careful that at base pacing should not capture the conduction system where it may confuse the interpretation. During parahygian or differential RV pacing, fast pathway conduction can preempt slow pathway and AP conduction, or a stable 1:1 slow pathway or AP conduction, and may be absent despite pacing at the slowest rate allowable by the sinus rhythm. Additionally, an AB nodal response can be seen with parahygian pacing due to nodovascular AP connected to the slow pathway. So what are the pacing maneuvers in long RP tachycardia? So first and foremost, must exclude atrial tachycardia and then think of AV node dependent tachycardia. So how to exclude atrial tachycardia? Do ventricular overdrive pacing or atrial overdrive pacing to look the VA linking or differential VA linking, delta VA, on stopping the pacing. Then atrial pacing at the tachycardia cycle length in sinus rhythm and look for delta H interval, which is if less than 20 millisecond, it suggests AT or PJRT, even in AT even less than 10 millisecond, whereas more than 40 millisecond, it suggests atypical AV-NRT. AV node dependent tachycardia, where atypical AV-NRT, PJRT or NF-NVRT, the best diagnostic maneuver is the His refractory PVC. And ventricular overdrive pacing during tachycardia and look for corrected PPI, TCL, SA, BA and delta HA interval. So these are the three things we should look. Differential VOP from base of the RV to apex of the RV already I discussed. And early part of VOP, nowadays you can look for early part of VOP as well, and dual chamber entrainment can be done nowadays. Mintu Tirokia has done from group have done dual chamber entrainment, both ventricular entrainment and same cycle length atrial entrainment, and keep the measurement which will more refine in long RP tachycardia as well. Parahygian and parahygian or hygian entrainment can be done in long RP tachycardia as well. This is the parahygian pacing where nodal response is seen, which excludes both AV-AP and nodoventricular AP, but nodovascular AP can do this nodal response. This is induction of the tachycardia with ventricular ventricular pacing, and where it induces by V to A, not VAA. So that induction tells that it's not atrial tachycardia, it excludes atrial tachycardia by that means. If it starts with VAAV, that means atrial tachycardia, otherwise it's a AV node dependent tachycardia. Here you see, this is a long RP tachycardia where there is RBBB, and when then RBBB goes, the increment, the rate fasting is only less than 20 millisecond, which is more common because it compensated by the slowly conducting pathway, and so the criteria which is used more than 20 millisecond for the septal pathways and more than 35 millisecond for the lateral pathways, right free wall, left free wall, may not be applied that amount. So here, if you see, you start the pacing and you see there is a delay in the AA circuit, AA cycle length, and then next beat terminates the tachycardia. That suggests it's a bypass mediated decremental pathway conducting tachycardia. So AT versus AV node dependent tachycardia on ventricular overdrive with entrainment from the short RP tachycardia, and AAV response is often considered diagnostic of AT, while ORT and AV and RT produce AVA responses, already well known. So however, AAV response, true AAV or pseudo AAV response are relatively common with AV node dependent long RP tachycardia. Pseudo is very common in long RP tachycardia because of long VA intervals and decremental conduction in the retrograde limb of the circuit. True AAV response during entrainment from the ventricle is due to retrograde dual response, maybe double fire with the simultaneous conduction over the fast pathway and or the slow pathway or slowly conducting AP. So dual response can occur. Pseudo AAV responses are produced when significantly pacing induced decrement occurs over the slow pathway, atypical AV RT or an AP, PJRT or NFRT, so that the paced VA interval exceeds the pacing cycle length, set VV interval. So, so the pacing interval, VA interval is longer than the pacing, than the VV interval. So this is a case of long RP tachycardia, which with ventricular extra, there is a atrial ectopic beats, which leads to induction of the long RP tachycardia here. And so all the differential diagnosis which I already told you, here most important is the look for the AV interval. And AV interval is shorter than the sinus cycle length, is suggestive only two things. One is either atypical AV node re-entry tachycardia or nodovascular nodoventricular tachycardia, not the PJRT. Not the PJRT or not the atrial tachycardia. So this is very important. And here, here spontaneous ventricular extra pre-excites the next A and reset the tachycardia. Here resets the tachycardia that suggests it's a bypass mediated tachycardia. And ventricular extra, slightly premature ventricular extra, when we gave, it terminated the tachycardia. So it proves that it's a nodoventricular pathway, and you mapped at the CS os, and with 2 seconds of RF, tachycardia terminated V without A, that means pathway has gone. Same thing, and on ventricular pacing after ablation, there is a VA dissociation. So no retrograde conduction of the pathway. So this is the site of ablation. This is, so another long RP tachycardia with 2:1 block. What is the mechanism? Here, this is long RP tachycardia clinical presentation, and on ventricle extra, there is a V and then A. There is V, then A, and then tachycardia change into 2:1 conduction. This tachycardia at least excludes, no, it's not ORT. It's not ORT. So it can be either atrial tachycardia or atypical AV-RT. So what we did, we gave one ventricle extra and becomes 1:1. And this maneuver suggests that it's a, and then other maneuvers suggest that it's a atypical AV-RT, slow pathway region ablated and terminated the tachycardia. Another I took from the study, from Reginald Ho publications, that termination unusual long RP tachycardia, what is the mechanism? Here again similar, 2:1 intermittent Vancouver type of tachycardia occurs, which becomes 1:1, leads to RBBB, sometimes LBBB, and on ventricular stimulation started and the tachycardia terminates. So even that indicates it's not atrioventricular pathway, but it's a nodovascular pathway connecting to the slow pathway region. And persistence of the tachycardia with 2:1 or 3:1, 3:2 infrahesion AV block with alternating left and right bundle branch block excludes PJRT and NFRT. So here the first pace complex is refractory and terminates the tachycardia with VA block, excluding atrial tachycardia, demonstrating the existence of an AP. While this finding excludes pure atypical AV-RT, atypical AV-RT can be terminated with his BPD if bystander nodovascular AP is present. In this case, the nodovascular AP injects specifically into the slow pathway of the AV node, retrograde limb, and the his refractory BPD conducts another 1 or 2 minutes. So his refractory PPT conducts over the nodovascular AP and penetrates the excitable gap in the slow pathway after the tachycardia wavefront has traversed the lower turnaround point of the AV node circuit, and its antidomic wavefront collides with the tachycardia, while its orthodomic wavefront encounters distal slow pathway refractoriness and extinguishes the tachycardia. This is the mechanism. And now rapid diagnosis of atrial tachycardia has been demonstrated by AV response. Suggest AV node dependent AAV response suggests your atrial tachycardia, but there are a lot of, if there is no entrainment, it may give false AAV response. If there is entrainment, but long, because you have to measure this AA interval, and if it's equivalent to pacing interval, that suggests it's a pseudo AAV response and not the, it says suggests it's a AV response, not the, and pseudo AAV response. Similarly, if entrainment has not occurred, it may give false AV response. Also, similar here, there is a true AAV response because of atrial tachycardia. And here there is a retrograde conduction, two sequences different and suggest one with the nodovascular, another with the fast pathway tachycardia. Here PJRT where long, you have to measure this and this is equivalent to 370 milliseconds. That suggests AV response and not the VA linking has been demonstrated to exclude VA linking is there, that suggests AV node dependent tachycardia and not the atrial tachycardia. So the since one place is stimulating one place and seeing the VA linking may confuse. So what these two study has demonstrated that you pace from 3 places and see the delta VA, and if delta VA is less than 14 millisecond or 10 millisecond, it suggests AV node dependent tachycardia. More than that suggests atrial tachycardia. This is a study, and so here this is the last, I think last case, and then we'll show if required. This is the long RP tachycardia here present when we give ventricular burst pacing. There is a VA dissociation. So what we did is we paced the differential atrial pacing was done from CS. We showed VA not linked, and then HRA it is 125, and when paced from CS it is 90 millisecond. That suggests it's a atrial tachycardia and not AV node dependent tachycardia, and ablated at the within 2 seconds the path within 2 seconds the tachycardia terminated at the CS os. This is the site of ablation. So now last is the most important maneuver is the His refractory BPD in patients with long RP tachycardia. And His refractory BPD, the problem first time it was given by Sailors, Gallagher, and he demonstrated all the maneuvers. In summary, they have written everything that if you have bundle branch block on the, say, you have to give ventricular extra from the, if the pathway is on the left side, you have to give the ventricular extra on the left side where your putative ingestion of the bypass tract is there, then only you can reset. Otherwise, you may not able to reset. Or if you have, say, pathway is on the right free wall, you may not reset from the RV apex. You have to have right bundle branch block to reset, so that excitable gap should be there to enter into the pathway. Similar thing, if there is a LBBB and pathway is on the left side, only then if you will give RV apex extra, it will enter into the circuit and pre-excite the atria. So A interval. So all these things has been demonstrated in 1976, and same thing has been. But the another
I think
problem
we have
is
to stop, Dr. Yadave. We're running short of time.
yeah. So decremental BPCs has been to be demonstrated. I thank you.
Thank you. Any questions for Dr. Yadave?
In a long RP, his refractory VPC will have a very good role, because as you showed in a case, this is the only place where there is no breakage or advancement, but it will be delayed. Only place where it will be delayed. But when I saw your example, it showed it was advanced. It's unlikely to happen in a PGRT. In a long RP PGRT, his refractory VPC is the only condition where the A will get delayed rather than advanced or breakage of the tachycardia.
No, it can have both effect. It can delay, it can advance also. It can delay also, or it can advance also. And if it delay, you have to give, you see, one BPC during his refractory should not be given. It should be given multiple to see that decrement is there. So the delay is further increased. That's why they demonstrated in one of the study, which I was just quoting, that if you will give, say, his extra you have given, now further pre-excite the his extra, but it should be within his refractory, and further delay, that proves that it's a bypass, decremental bypass tract.
I think the only important thing is the pathways are never decremental. Only PGRT is decremental. So that's why it can never have an advancement. How can it have an advancement? It has to have a delay.
If it is delayed, that confirms it's AVRT, most probably PGRT. But if it advances,
no,
it delay rules out AT or AVNRT. That's all you can say. But you can't say that in PGRT it will always get delayed. It can advance also.
It's not specific.
No, sir. This is not 100% true. Let me tell you. You see, if the fascicular, if the nodofascicular connection is there with the slow pathway, you may delay the next ventricular, his refractory BPD may delay. You have to look for other mechanism, atrial pacing during tachycardia. I have that slides. that demonstration of that tracing where you can delay, and that is not because of PGRT, not because, that is because of nodovascular connection or nodoventricular connection to the slow pathway region. And that can also terminate, that also doesn't prove PGRT. It can delay, it can terminate because it connects to the slow pathway region, turnaround point. If you can make the slides, I can just show the.
I think we'll
Okay,
stop.
okay. So, I can show you these individual cases where it can have without PGRT. It's because of nodoventricular, nodovascular bypass tract to the slow pathway region, which delays, which can terminate also. You have to use atrial pacing maneuver. See AH interval, what happens about the AH interval. Dr. Mann's the 1995 publications. So if AH interval increases by 40 milliseconds, AV node dependent, if below 40 milliseconds, it suggests either atrial tachycardia or it's a
that you're talking about is the
bypass
AH delta.
Yeah?
What you're talking about is the AH delta. That's another maneuver which you said. That's AH delta. If it is more than 40 milliseconds, pointing to
AH delta, yeah. So, but you have to look all the maneuvers. And lot of maneuvers are there. You can use all judiciously. It's not that you have to use all the, and let me tell you this corrected PPI TCL and SABA may long RP tachycardia may be overlapped. You have to look for delta HA, which is given by initially by Miller and then by Reginald Ho. During tachycardia, they did this delta HA interval, that is by Reginald Ho, and Miller during sinus rhythm, you pace at the rate of tachycardia.
Thank you, Dr. Yadave. I think you can continue the discussion with the delegate beyond this. I now invite Dr. Anand to come and give his talk on management of junctional tachycardia.
Good morning, everyone. I am Dr. Anand from Christian Medical College. At the outset, I thank the organizers of IHRS Kolkata for giving me this opportunity. My topic is on junction ectopic tachycardia, approach to management. I'll be talking on mainly about post-operative jet. I'll be covering under the following headings, mainly definition and clinical features, etiopathogenesis, ECG, presentations, treatment and preventive measures. Coming to definition of jet, as the name says, junctional ectopic tachycardia. So tachycardia should arise from the AV node or the His bundle region, which is the junction region. Rate of the tachycardia is more than 95% of heart rate for age. This jet occurs mostly in the pediatric age group in the post-operative cardiac surgery settings. Many of the studies have taken 95% for the heart rate. Some have taken 98%, and for simplicity purpose, some of the studies have taken more than 170 beats per minute. There are two forms of jet. One is the primary jet, which is idiopathic, usually occurs in the infantile group, usually less than 6 months of age, and usually it is an incessant leading to tachycardia myopathy. And rarely it can also occur in the adult age group. Secondary jet is the one which I am going to discuss about. It is a post-operative jet which occurs in the post-cardiac surgery setting. So post-operative jet, the incidence varies from about 2 to 22%. It occurs most commonly after about 24 to 48 hours after surgery. It is usually self-limiting, usually settles within a week or so. Even though it is more common in surgeries involving the AV junction region, predominantly the surgeries such as TOF, VSD, AV canal defect, and ASD, and very rarely it can also occur with surgery which does not involve the AV nodal region such as Fontaine operation. Even though it is self-limiting condition, it causes hemodynamic instability due to the rate and also because of the AV dysynchrony, and which can lead to prolonged ICU stay and mechanical ventilation. Coming to the etiopathogenesis, abnormal automaticity is the mechanism by which it's initiated. There are multiple factors which causes this abnormal automaticity. Coming to the surgical related factors, it can be direct and indirect. Direct factors are one which causes a myocardial incision near the AV node. Second is trauma to the AV node, which can be suture related or handling of the AV nodal region. And indirect causes like prolonged cardiopulmonary bypass, smaller hearts. As you handle the small hearts, they are more prone to trauma and complexity of the procedure. Coming to the
factors in the perioperative period, post-operative period, mean the use of inotropes in the post-op period, and post-op period is per se is an inflammatory state, and electrolyte imbalance, predominantly hypomagnesemia and hypokalemia. So it's and the other thing is genetic susceptibility. As Dr. Beamsekar said in the previous talk, ACE angiotensin converting enzyme, gene polymorphism, insensin and deletion genes have been found to be associated post-operative JET, and also troponin I interacting kinase gene has been associated with the primary JET. So all these factors can cause abnormal automaticity. This indirect factors like surgical related, like prolonged cardiopulmonary bypass and inotropes and desolectomy indirectly causes a longer ischemic time, causes also reperfusion injury, and there is a more inflammatory response. Because of this indirect issues, there is a HCN channel gets upregulated, which is the hyperpolarization activated cyclic nucleotide gated channel, which is a fundic current channel. This HCN channel gets upregulated not only in the SA node, also in the AV nodal region. That's why it causes a, HCN gene upregulation leads to increased abnormal automaticity and JET. Coming to the ECG features, JET as is arrives from the AV junction region, it is usually a narrow QRS tachycardia, usually has AV dissociation. Occasionally it can have a narrow QRS tachycardia with only stone VA conduction, where the differential on ECG is AV NRT. And infra-Asian conductions, when usually JET occurs in the patient with a junction AV nodal trauma, so there may his bundle branch block may be there. So in this case, it may present with white QRS tachycardia. In that case, a VT is a differential diagnosis. And even though it's usually an narrow QRS regular tachycardia, it can be, the rate can be irregular due to intermittent sinus capture beat from the, or because of warm up and cool down phenomenon. Since it is a mechanism is abnormal automaticity, this is usually responsive to electrical cardioversion, programmed electrical stimulation, or overdrive atrial pacing. If the tachycardia is not responsive to these things, then you have to think about JET and not AV and RT or other tachycardias. If on the ECG, if you don't clearly see the P waves on ECG, we know, then if the patient has an epicardial atrial pacing wire, that can be connected to a EP stimulator to look for the EGM, and helps, which can help in determining the A and B relationship. So this is a post-op patient with a TOF, 18 years old, who presented with who had a post-op had a narrow QRS tachycardia with rate around 160 beats per minute. If you closely look at the rhythm strip, you can clearly see that the P waves are clearly dissociated from the QRS. So it's a junctional tachycardia with BA dissociation. The same patient and another time had this irregular rate. It's a junctional tachycardia. This is irregular due to the cool down and the warm up phenomenon. So coming to the management, the goals of management of JET is first important goal is to maintain a restoration sinus rhythm. In all cases, it's not possible. If sinus rhythm is not easily restored, then you have to go for the reduce the rate of JET, so that it improves the hemodynamics, and other measures to be taken to maintain the hemodynamics. So there is a staged approach, or people use a multi-pronged approach, where all these measures can be taken one by one or at the same time. So the approaches can like gentle measures, anti-arrhythmic medications, then pacing, and finally is hypothermia. Coming to the gentle measures, you have to correct whatever is abnormal, mainly if the patient has in fever, hyperperxia, it should be treated. Electrolyte abnormalities, mainly hypomagnesemia. It is occurs because of diuresis, and also because of blood transfusion, hemodilation during the procedure. So all can lead to hypomagnesemia. Studies have shown that IV administered magnesium prophylactically has reduced the incidence of JET, correction of anemia, correction of hypovolemia, and sedation and analgesia also is found to reduce the rate of JET, and always minimize the inotropic support. And most important thing in gentle measures is avoid DC cardioversion. This is because it not only is ineffective, but also by cardioversion there may be myocardial depression, which can further worsen the hemodynamic instability. Coming to the antiarrhythmics, amiodarone is the one which has been extensively studied and used in JET, and amiodarone should be stopped once the sinus rhythm is attained for more than 12 hours. Since it's a JET is a self-limiting condition, once it gets sinus rhythm is such, you can amiodarone or any other antiarrhythmic can be stopped after about 12 to 24 hours. We all know the antiarrhythmic side effects of amiodarone. Mainly it causes hypotension, bradycardia, and AV block. Usually it transient and it improves its supportive muscles. Beta blockers used mainly to reduce the rate. Other medications like procanamide, digoxin also have been useful. Ivabradine, I'm coming to the ivabradine in the next slide. This is taken from JACK EP. This is presented by the AIMS group. This is a randomized control trial comparing ivabradine versus amiodarone. It was they found that ivabradine was non-inferior to amiodarone in control of jet and so as I already said, it is an inhibitor of the funny current, which is the HCN channel. So what happens is, as HCN channel is blocked, the diastolic depolarization is delayed, thereby reducing the rate of the jet. So usual dosage in the pediatric age group is 0.05 milligram per kg to 0.1 milligram per kg every 12 hours. If there is no response, you can increase up to a maximum of 0.2 milligram per kg. And again, once the sinus rhythm is sustained for more than 12 years, you can stop ivabradine and wait and watch. The major advantage of ivabradine when compared to other antiarrhythmics is its hemodynamic profile. It is only has a heart rate reducing effect with no effect on inotropy, lusitropy, on cardiac conduction. Another important is the maintaining the AV synchrony. Because jet causes hemodynamic instability due to two reasons. One is due to increased rate, and another is due to loss of AV synchrony where A and V are contracting simultaneously. So if you reduce the rate of jet by general measures, medications, or by hypothermia, even though you don't restore it, then we can do AV sequential pacing to maintain AV synchrony and improving the hemodynamic. So there are various strategies for cardiac pacing in jet. First is AA pacing, then is the DDD mode pacing, then the paired ventricle pacing, and AVT mode, which is called the R-wave synchronous atrial pacing. The last one is the most found to be more useful. So this is as any automatic tachycardia, the rate of the jet usually increases as after surgery. This is the acceleration phase and the deceleration phase. So if you want to have a AV synchrony, you have to pace more than the rate of the jet. So AA pacing, you have to pace like more than about 10 to 20 beats per minute. And as you increase the rate itself, that also can have an hemodynamic effect on the hemodynamic stability. However, this AA pacing cannot be useful if the patient has heart blocks. Second one is the DDD pacing. Again, you have to pace faster than the jet rate. And here you have to, it will be useful in patients with heart block, but we're pacing the V, it can cause dysynchrony and that also can sometimes worsen the ventricular dysfunction. Another one is the paired ventricular pacing. This was devised by Waldo. So what is it? It depends on the principle that the electrical refractive period is different from the myocardial refractive period. Here you give the two impulses S1, S2, which is given continuously at the rate more than that of the jet rate. So that S1 depolarizes the ventricle causing the QRS. S2 also depolarizes and causes the QRS. But however, S1 causes myocardial contraction leading to the arterial pressure. But the S2, even though it causes QRS, the myocardium in the refractory phase, and it will not cause any contractility. So thereby the effective heart rate is reduced and improving the blood pressure. However, it is not commonly used because of its complex technique. You need an EP stimulator, and there is no AV synchrony, and you have to frequently adjust it. The most important easily and is the R-wave synchronous atrial pacing, which is AVT pacing. Here you sense the jet QRS, then after the set VA delay, you pace the P, and after the AV delay, the spontaneous jet QRS occurs. So this can be usually done by just we have a dual wires, one in the atrium, one in the ventricle. The atrial wire is connected to the ventricular channel and the ventricular wire is connected to the atrial channel and can be easily done. It is more physiological. There is no V pacing and you can monitor the jet rate. Coming to the hypothermia, the next is hypothermia. It can be used concurrently along with other measures. As hypothermia causes shivering, just 30 seconds or so. It causes shivering. If you have the patient be completely sedated, paralyzed, and put on mechanical ventilation. Hypothermia can be induced with the application of ice packs, cooling blankets, fans, or by lavage, which can be gastric lavage with cold saline or IV cold saline. Rectal temperature is monitored 32 to 34, usually will be 33 to 34. Very rarely you can go up to 32 degrees C, and keep it for minimum of 24 to 36 hours. Once the patient is stable for 24 hours, then you start rewarming at the rate of 1 degree C every 8 hours. It reduces the jet rate and improves the hemodynamics. Prevention may use of IV nitroprusside is found to be useful. Perioperative use of propranolol, administration of IV magnesium in the perioperative period, and perioperative use of dexmedetomidine. So dexmedetomidine is a selective alpha-2 adrenoceptor agonist. So by acting on the CNS, decrease the release of norepinephrine and also stimulates the vagal nerve, and it has been found to reduce the rate of incidence of jet, mechanical ventilation, length of hospital stay. However, there was no mortality effect on mortality in this period. So take-home message is post-operative jet is more common in the pediatric age group. Its pathogenesis is multifactorial. Diagnosis based on the surface ECG with differences usually consider AVNRT, and if it's a white curious, it's VT and AF. Early diagnosis, early intervention is important in order to reduce the morbidity and mortality. And also rapid escalation of therapy. If one of these measures is not working, you have to rapidly escalate. Thank you.
Thank you, Anand. Any questions to Anand on jet?
So this is a pediatric age group. So if it's adults, some of them have just ablated in a slow aviodinal region. If it's not working, and then probably with the risk of fibula. Yes, some. I'm not saying all cases. Very few cases they have gone away with. Yes. Other thing, they would, may have to go to the anteroseptal region, but the risk of AV block is high. So. Okay, sir. Okay, sir.
Thank you. We'll close the
Thank you,
session.
Thank you so much. Now we will move on to the next session, which is based on, it's a keynote lecture. And for this, I would like to call on stage the chairpersons, Dr. Ajay Nayak and Dr. Anil Saxena. I request you, sir, please come on the dais. A warm welcome to both of you, and would also like to invite our first speaker, Dr. K.K. Talwar.
Good morning, everybody. So I welcome you all to this very important session on a career in electrophysiology. Now, this is of particular interest to young budding electrophysiologists who have been who aspire to a career in cardiac electrophysiology. Electrophysiology is a relatively new specialty, and for the last 25, 30 years, we have been working in it. And there are numerous problems which the aspirants for a career in electrophysiology face, right from low volume to low compensations to various requirements that it entails. A career in electrophysiology entails in terms of equipment, which is very expensive, and the reimbursement which are very low. So many of the aspirants eventually start doing other things like intervention, etc., and find it very difficult to sustain a career in pure electrophysiology. So we have the best person to give us a detailed overview of how to build a career in electrophysiology, Professor K.K. Talwar. He has been a professor and head of Already Institute, and subsequently has had many important positions in the regulatory structure as well. And he was one of the pioneers of cardiac electrophysiology in India. And he can guide us about how to build and aspire for a career in cardiac electrophysiology. Over to you, Professor Talwar.
Thank you. Good morning, everyone. I think there is some pen drive had some issue with that, and then they're trying my own laptop. I think I first also thank the organizers, Dr. Majumdar particularly, for this opportunity. And it's okay. I'm like to share with you, I think, briefly about some few historical facts. Before I really go into this, we had some discussion yesterday night when we were in the sort of, so that, I mean, and this is important, I think. I feel that in future what we should be looking at. It's okay? ये मेरा laptop दे दो.
Actually, we've been having these discussions over years during conferences, sir. And when the Monday morning comes, everything is swept apart when we get the patients. We are overwhelmed by the patients. So it'll be nice that you've consolidated all thoughts and we can hear you.
As far as YEP is a fascinating, or I mean, as a career, what attracts is mainly because it's very fascinating subjects. In cardiology, I think we are very tuned to procedures. You need skills, but here, apart from skills, you also need some analytic mind. And not all career, unless you have that kind of a little mindset, you really can't go into this kind of very interesting area. And it was around 70s when the EP actually started. And that was a time when the cardiology was limited. We didn't have an echo. We were just doing in the lab catheterization for rheumatic heart disease, congenital heart disease, routine cases. And that is when this area came, and making interesting to how to look at the electrical system of the heart. Of course, in 80s, with the coronary angiography intervention, this field became less attractive to most of the younger people. But I think with then RFA initiation and other devices for heart failure, sudden death, I think there has been now again very attraction to this particular specialty. I think historically, if you look at, took about nearly, I'll say, 100 years to us to really get into the electrical activation or recording from the heart. I mean, if you look at 1945 was the first when Purkinje fiber was described. So I think innovative work of many of these distinguished scientists led us to understand the electrical system of the heart. For sake of time, I will go a little quickly here, but this was only 1940 when that catheter could be used to record the intracardiac electrical signals. And Furman's observation that heart can be stimulated by connecting intracardiac catheter to stimulator led to the development of pacemaker. Of course, it was 1969, the first paper which came from Dr. Sherlock, the first time he described that you can record his bundle. So now we knew what is AH interval, HB interval, and other kind of development, and subsequently, I think a number of our senior legends in electrophysiology, their work, Dr. Balance, Dr. Chive, George Sutton, Gallagher, I think they made us understand that how the electrophysiology became attracted to understand various supraventricular arrhythmia, ventricular arrhythmia, and then in mid-80s came that you can by catheter ablate the AV node. It was initially with the sort of electrical defibrillator, but I think this energy was not very attractive because of various limitations, and then the interest and the work continued till they found that RF, which is very safe, simple, and I think that totally changed the outlook of electrophysiology. Of course, Professor Hasegre's work indicating that there are spontaneous emission of AF by ectopics from pulmonary veins that led to the more understanding of atrial fibrillation and also ablation area in that. If you look at in India, electrophysiology, it was, I think, 70s when we were growing in cardiology that in Pant Hospital, AIMS and PGI, initial work on electrophysiology started. I think it was an interesting and fascinating field, and as I mentioned, RF initiation certainly changed the outlook of this particular specialty. RFA procedure, I think, in AIMS was initiated in 1993, and then of course ICD, CRT, and kind of development made this area very attractive, and many centers in the country many youngsters start going into electrophysiology. Now I like to share with you what, briefly just what made me to like this specialty or get into this specialty, what are the opportunities and strengths and challenges as a career for young aspirants, I think which is probably the core topic today. Is I say fascinating in 70s when I mentioned to you that it was only very limited cardiology work in the cath lab. We start working on electrophysiology. Because of its diagnostic nature, it was becoming little not very attractive because other areas, as I mentioned, coronary intervention was coming. During this time, I came across that in Sweden, they were doing the monophasic action potential signals. By the help of catheter, suction catheter, you could record signals and then study the effect of antiarrhythmic drugs. So I think Praloy, I don't know whether he's here or not, this is one of the, he was talked about an animal experiment, that there is a technique that you can record a kind of a action potential from the inside the heart by these catheters. So I went there, tried to learn about it, brought back some of the equipment to reshape this area, but this was again more of understanding the, more of research area, that you try to study the antiarrhythmic drugs, how does it alter the refractory period, prolong the action potential duration and all that. But during this period of mid-80s, when the radiofrequency ablation came into the scene, and that chose, because of therapeutic nature, became extremely attractive. That's when I went to Milwaukee. I spent a few weeks there, and Professor Masood Akhtar and his team, and Dr. Sarah, of course, comes often with us. Dr. Natali was doing fellowship that time. Even Claire was also doing his fellowship training there. So this was that initiation of RFA procedure in 1993. I'd like to share with you what difficulties we had when we started this kind of field. We had a very simple mingograph. We could not get a EP recorder. It was very difficult to ask the administrator to give me money to buy that dedicated. It would not have been possible to start immediately. We have a Mingo 6-channel and a one AppCore was 12-channel. We had a Medtronic stimulator with 2 stimuli was lying in the department. And then RF ablator I could get with the help of that from Milwaukee group. And this was a limitation. When you attach the RF catheter to the ablator, your signal will go away. The lesion will come, but you can't see the signal at that time, whether it's a good signal or not. So these were the limitations. This was the kind of recorder that we had. But within 2 years, we published our first 200 cases of SBT. This was in 96. And we had a very good results as comparable to any center outside, both for AVNRT and for the AVRT. And and we also published a few the initial experience of idiopathic ventricular tachycardia using all these primitive kind of options available to us. Just to show you this 6-channel recorder. So, and it was useful to sort of, that was ABRT, this was a BT. You see his Purkinje potential. But you see, when we ablated this patient, that time you can't see the signal. So these were the limitation. Of course, we soon got the dedicated equipment. We also got CARTO in the department 2002 or so. So that's how, these are the colleagues who were associated in AIMS. I think Rakesh Yadav is now the secretary. Unfortunately, we lost Dr. Janeja, who initiated pediatric electrophysiology in the country. Unfortunately, at a very young age, destiny took him away from us. And then few colleagues when I went to PGI, Dr. Manoj and Dr. Rajiv Mahajan. Now let me come to the crux of the issue, that is, it's certainly a very fascinating and newer options are making it more fascinating. You cure patients with SBT, you cure most of the patients with BT, you provide now devices for heart failure, for life saving. So there's a lot of satisfaction what you do in the lab or in the department and to help the society. And the new opportunities making it more attractive. You have 3D mapping, various systems. Now pulse field ablation is coming, which may be a little better than RFA. And for atrial fibrillation and for other arrhythmias, we have a conduction system pacing, you have wireless pacemakers, you have leadless pacemakers. So I think all these kind of new technology which has come into this field is making it very, very attractive field to work on. Of course, you have to have the analytic mind. Now, what are the challenges? Of course, it requires rigorous training and long study period. Electives must be adapted to analyze. I think as mentioned, the analytic mind is important. Not all cardiologists get attracted to electrophysiology because you have to think about it. It's not only doing procedure, but analyzing the whole things. And then device implantation, you have to learn the training to implant, program, and handle troubleshootings. The issue which is, now is the career financially satisfying? I talked to some of my junior colleagues who have been in this, just to ask them, will you be adopting as a full-time EP career? Remuneration, salary satisfaction, I think this is one issue I could get. Government sector, no issue. Every faculty get the same salary, whether you work for one area, other area, there is no difference. But it comes to private and corporate sector, when the salary is related to your earning, how much you are generating for the hospital, they probably decide about your remuneration. And the major issue is there is no regulatory control or certification of training in our country. And with this reason, how to prevent the non and half-trained professional to do these procedures. Even cardiologists with limited knowledge start implanting devices. No regulatory mechanism to ensure that only trained in the subspecialty will do this, unscrupulous pacing, even half-trained people get technicians from the firms and do kind of a mapping and ablation, which is, I think, now this one patient who had a pacemaker, AVR was done, patient had a high threshold atria, but sensing all the time, the person changed it to BVI pacing, thinking it's a high atrial threshold. And patients start getting symptoms, and then you reprogram. So what I'm to say, it's not only implanting, understanding and program is very vital. So important for the growth of, we need to have a regulatory mechanism, we need to NMC, and I think IHRS should take a role and try to approach these bodies, construct a kind of a program with periodic certification, and only those who are trained should be doing these kind of a procedure and not those who are not certified. I'll just briefly, in America, what happens, the cardiology training, they have this core cardiology training symposiums. They make groups, which then construct the curriculum, training program, certification, and then this is the kind of, they have gone, COET was 1995 first, and further upgraded to 2000, last was in 2015. So this is what is like, that you have a board which accredits a place for this course, then you have a certified specialization, they certify it, and these three, and ACC or AHA, they work in collaboration. So CSI, IHRS, we should work in collaboration with them to try to create these kind of possibilities and programs. So I'll just say this is the kind of the quote to say, that you have a basic knowledge and then you can do certain certification or do advanced training in EP or wedge intervention kind of a thing. So these are the way I think, but then only people I'll say that these are the three levels they considered. Basic cardiology, then some specialized echo certification or maybe MRI certification that you can do those kind of studies, and of course level 3, more advanced training in different areas. Now, if you look at electrophysiology in the country training program, there are a number of institutions which are doing some course, some doing 1 year, some doing 2 years, some doing less than that. So I think there's no uniformity as such. There's no certification as such. So I think as a but should be done, IHRS should take the agenda, IHRS should constitute a committee, draw a curriculum for training fellowship in EP. I think Dr. Clear was mentioning they have made something that can be looked into. Some of the centers who have initiated fellowship program should follow a uniform pattern, and IHRS should approach the national board, NMC, for having a initiating fellowship program which should be certified, and if it is necessary, we wish to attract youngsters to have a dedicated EP career. And that is, I think, is important, because I think Professor William Hurst once mentioned that for motivated trainees, achievement might be best supported by open-ended fellowship program with minimal structure. But the problem is, he lamented, because we do not live in Camelot where all is perfect, we must have some basic standards. So we need to sort of have our training program, but we are already, we feel proud that our youngsters are doing very well. This was in 2009 APGRS when they got the Indians team, got the younger people, got the award for electrophysiology quiz. So I think the way forward, I had to say, I think the past president, the present president, they are both here. And like say that There's a time to streamline medical education and specialized fields in the country. Adequate attraction by due remuneration and opportunity to grow should be there. IHRS should take lead in creating education program with certification by the regulatory bodies. IHRS may initiate consensus guidelines. This is also important because people are doing procedures which are not sometimes indicated. It is relevant to our society for various procedures to ensure to follow guideline-based evaluation treatment. Dedicated expertise is important for original thinking and innovation. And today we are certainly doing a lot of good things, but we are not leader in medicine because we are not able to innovate anything new. We are only following. If we have to get into that aspect of medicine, I think we have to localize ourselves. We have to encourage that kind of a concept so that our youngster can think more, do more, and we can be claim sort of show to the world that we can also lead. Thank you so much for this patient's hearing.
Thank you, sir, for a very comprehensive overview of history of electrophysiology and then about the career in electrophysiology. Sir, we have been working with the National Board. I myself, as when I was president, I went and met the director of National Board, and then Dr. Clare has done some work on that. And they have, 2 years ago, they started the 2-year fellowship of National Board. Last year was the first time that candidates, because it was not, awareness was not there. So we, in our hospital, we have one fellow from National Board, sent by National Board for 2 years fellowship, and 2 or 3 other centers also have. So about 8 or 10 centers are now inspected and accredited by the National Board for this fellowship in electrophysiology of 2 years. Just like we have for intervention, cardiac surgery, cardiac anesthesia, we also have for electrophysiology. So it's a running thing now.
You see,
And
please go ahead.
so we already have one person being trained by the National Board.
See, the question is, Dr. Anil, that now any center in the country which does then should follow the same kind of a thing. You have center which are doing.
So it is the same thing, sir. So
No,
National Board
it is
has.
only for these few centers, but there are many other are doing. Like yesterday, Jayaprakash mentioned. They are
Yes, so we mentioned,
You see,
so-
CMC Belore is doing, Pondicherry is doing. They are not doing the National Board ones.
Sir, but they had started this 8-10 years ago because of lack of National Board.
Now that we have National
now
Board.
we may be able to conform it.
You
into
should
this.
have the fellowship uniformity. Let the medical and NMC also adopt.
Yes,
number
sir.
one. Number two, then these dedicated individuals should be certified only do those procedures, unless you are able to prevent the others.
Right.
So then one sees what is it, there also others are also doing. So if we have to strengthen, attract them, then they feel that after training, they are the one who are qualified to do it. But in our country, that kind of regulation is not there.
So that structure may be difficult to get because, like, for example, Shri Chitra is an autonomous institute. They are free to start any program. Nobody can direct them. JEPMER and many, even All India Institute, can, if they want, if they choose, they can start whatever program. It will be automatically approved by the MCI. And in many states, like yesterday, Dr. Clare was also saying that there are DM programs. Now there are so many other issues involved, like the state government don't want to lose their power, the politicians don't want to lose their power, the HODs don't want to lose their power. And in many private colleges, these degrees are being sold at a very high price, so there are financial issues involved. And they also influence MCI not to combine the two streams. So there are, I think it's a very, very complex topic, and probably it may or may not happen. A lot of political will is required for that.
If I may add a couple of points, even if it is Jaydeva or Pondicherry or whatever, they have the program, but the requirements are more or less the same. It is going to be 20 defibrillator implanters per year, or 50 pacemaker, or 50 EP procedures, because essentially they have been adapted from the same kind of documents. So it is semantics trying to differentiate between what those centers are doing and what the National Board is doing. Essentially it is the same. So there is no harm till finally everything comes in unison and confluence and creates a single body. They are essentially doing the same thing. And even if they are certified from these centers, for the next 4, 6, 8 years till the confluence happens, I think it is pretty good. It is pretty
I don't doubt. You see, these are good centers which are doing it. But what I am trying to say that some are 1 year, some are 2 years. There should be some kind of uniformity. You cannot have 1 year somewhere and 2 years somewhere and then say, I am also trained. That's one. The other aspect is that we need to certification and then these to be followed. Here is what the regulatory body should take a call. Both the NMC and the national board, that unless you are trained, suppose tomorrow there is a complaint, you are not entitled to do these kind of things. So these kind of this we should impress. IHRs, these bodies should approach these organizations to impress upon them in the interest of the development of the thing.
Yes, sir. Like, for example, Delhi Medical Council registers people, and additional qualification has to be registered. For example, cardiology degree has to be registered before one can be called a cardiologist. So all of us had registered. So you're right, absolutely right, sir. The NMC should basically enforce it.
We have to work on these bodies. Now, as far as you said about the money issue was there before the NEET, when the capitation fees were happening.
Yeah, so NEET was again, there was so much resistance for NEET.
I was involved in that, yes, I know. Sir. At least we thought that is the only way. That time the NEET was the only way to stop capitation.
Yeah.
So there are problems with NEET also. We realized that we should be modified subsequently. Like you have to co-act 94. 1, 2, 3, 4, 5. Some or the other, we need to be working regularly on those aspects. Here is one we lack, and unless we try to little sort of be, I mean,
absolutely, sir. I completely agree.
Those things are happening.
The society should work engage with these people.
Not to be individual, it should be by the societies, because that makes impact.
So your words reflect the experience you have in the academic, administrative and regulatory field. We really appreciate what you've done for us today. Thank you so much.
Thank you.
Thank you so much, respectable doctors, for this session. And now we will move on to the next session, which is based on the VT. And for this, I would like to invite on stage the chairpersons, Dr. Anup Gupta and Dr. Sai Satish. A warm welcome to both of you on stage, and would like to also welcome on stage our first speaker, Dr. Praveen Srikumar.
Thank you, IHRS, for giving me an opportunity to present. I'll go straight away to the topic. After an inspiring lecture, this is going to be a clinical topic. Sometimes electrophysiologists need not be an analyzing mind. Sometimes you have to act fast. This is one situation where you need to act faster than probably an interventional cardiologist. And electrical storm is a life-threatening, is defined as a life-threatening state of cardiac electrical instability characterized by repetitive clusters of sustained ventricular arrhythmias over a short period of time. Generally, the definition is 3 episodes of sustained ventricular arrhythmias or appropriate ICD therapies, each episode at least 5 minutes apart in 24 hours. So it can 80% of the electrical storms are sustained monomorphic VT, rest 20% either polymorphic VT or torsades or VF. So the general incidence is around 4.7%. This is from the observer registry. And generally, the secondary prevention ICD, this is an ICD registry. So it has been seen that around the secondary prevention patients, there is a 10.5% incidence. It's higher in the patients who already have a ventricular event. So it can occur both in structurally abnormal hearts and normal hearts. Structurally abnormal hearts, most common is the scar VT or non-ischemic cardiomyopathy with scars or sarcoidosis and any abnormal scars like post-myocarditis sequelae, and structurally normal hearts also like long QT syndrome, Brugada syndrome, channelopathy VTs, CPVTs are drug-induced. So most patients with ES have a pre-existing ICD because that's the tip of iceberg that we get. It is those sort of patients often who land up living. The rest of the patients are not living. That is the lower part of the iceberg. And risk factors for generally, these are quoted risk factors for ES. Although any person with channelopathy can suddenly land up in electrical storm, that may be their first presentation. But generally the risk factors are of patients who come to survive to casualty are lower ejection fraction, older age, wide QRS, lack of appropriate guideline directed therapy, or often the beta blocker under dosage, CKD, previous ventricular arrhythmia episodes. These are the known risk factors. And by itself, ES is a risk factor for sudden cardiac death in patients on ICD. And generally, there should be a substrate and a trigger. Usually, substrate are either its underlying channelopathy, which we don't know. Genetics will not have been done in general population. Sometimes they may have a genetic analysis report with them due to previous syncope evaluation. Or myocardial scar noted on cardiac MRI. A huge scar like this may be a harbinger of ES. And there usually is a trigger. Either it's an electrolyte derangement that is most common, which should be corrected fast. Ischemia is the most common. Second will be electrolyte derangement. Or they may have an underlying undiagnosed heart failure, new inflammation, viral myocarditis, or any other like genital myocarditis or drugs, prolonging QT. And there is an overlay of autonomic dysregulation. Either sympathetic activity or even vagotonic induced arrhythmias are also common. So they act on the particular substrate and form, they cause the electrical storm. And we need to know the etiology of the storm. What is the patient that we are dealing with to manage a storm? Just by when a patient comes to you and a call comes from the ED physician, you have to know the history, a light history, at least to know what we are dealing with, because it is cost-directed definitive therapy for each patient. So each etiology has its own form of treatment. So the general substrate in a structural heart disease is a scar. So it's a scar-related re-entry is a basic mechanism in most of the structural heart disease. Or it may be automatic mechanism like VPC arising from Purkinje fibers in a scar border zone. And so either of these three mechanisms can happen: re-entry, enhanced automaty, or triggered activity. They can all occur in a scar. So in non-ischemic, it is usually a scar-related re-entry. Usual ES presentations are mostly with ARVC, sarcoidosis, Chagas, and in our country, we should not underestimate myocardial tuberculosis because that is found to be very common in our own studies from multiple places. And giant cell myocarditis is another cause, which is rare in our situation. And substrates in structurally normal hearts are either non-correctable, like ion channelopathies. So sometimes they are not correctable. And there are correctable channelopathies also, and prolonged QT interval. So they predispose to bradycardia dependent TDP. That is another cause of VT that electrical storm that we commonly observe. Even in a complete heart block, you can have a brady induced TDP. And idiopathic VF can be initiated by short couple VPCs. That is another cause that we see. That's a very ablatable VF or ES. And initial management depends on the clinical context. We need to know the history of the patient, a short history, what we are dealing with, arrhythmia characteristic, triggers, cardiac substrate, hemodynamic state, and risk profile. This decides the management. Generally, when a patient comes to ED, they have to be taken care of in the ED well. First importance is to stabilize the patient. Just we need the patient live in our cardiac ICU. Before reaching cardiac ICU, in casualty itself, we need to know the short history from the bystander. If bystander is not available, if the paramedic team has brought them, then we need to depend on chest X-ray. Whether they have an ICD, you can palpate an ICD. Where it's a snare, then immediately call the ICD tech to at least interrogate the device, or the resident need to interrogate the device and inform the consultant. So these need to be known to the ED physicians. They need to know that you are dealing with the ES patient. That's the first thing. So ES patient has to be categorized as a high priority patient in a cardiac ICU. Often a point of care ultrasound is required, which is echo, to know whether the heart function and other parameters. So once the initial stabilization happens, most of the management of ES is in ED rather than cardiac ICU. Before reaching cardiac ICU, we can even program an ICD. ICD management in ES is most important. And the immediate goal of treatment with ICD in patients with ES is to avoid repetitive shocks, ineffective shock, or to find if there are inappropriate shocks to stop that. Then device reprogramming. We can even apply a magnet over ICD, which immediately sustains the VA detection so that we can manage the patient like any other patient without a device. If sometimes it's a slow VT, so we can change the ICD detection rate immediately in the casualty itself. And all patients need to have an ICD defibrillator pad before shifting to a cardiac ICU. In these days, that is a safe method to shift them to a cardiac ICU. So you can quantitate, the ICD interrogation is mainly to quantitate, to know what the arrhythmia is, whether it is running a VT, a slow VT. So immediately we can change the rate of the VT. So you can determine whether it's an appropriate or inappropriate shock. and so you can assess the VT morphology, you can see the onset of arrhythmia, and you can recognize whether there is a effective shock or non-effective shock, and it also allows reprogramming of ICD. And sometimes atrial arrhythmias, fast ventricular rate, T-wave oversensing, or a lead noise causing inappropriate shock, all can be managed immediately by, at least first, if we don't know, we can just switch off the device and manage them medically. So if it is an appropriate shock, we can even change the ATP. ATPs, they are a double-edged sword. Sometimes they trigger a VES, or sometimes, most of the time, ATP do a shock-free termination of VT. That is found in 75% of monomorphic VTs. You can either increase the number of cycles of therapy, increase the number of bursts per ATP cycle, or decrease the ATP cycle length. That is, percentage of the cycle time can be decreased more than the set cycle length. Suppose it is kept as 80%, you can change it to 60%. Suddenly the VT may abort, and give one more ATP, it will abort. Or you can even do a RAM plus, or change a burst plus, or a RAM programming. So these are methods with ATP programming, or ATP changing the ATP programming to terminate an ES VT. So sometimes devices are pro-arrhythmic. ATPs are not always therapeutic. Sometimes they degenerate fast into EF just because virtue of that you have programmed it to an ATP, or change the programming to more number of ATPs. So sometimes patients who have recurrent VT episodes, we can program more of shocks rather than more of ATP. So you can change the programming to that way. So because low energy shocks may accelerate VT, and sometimes you may have to, especially sometimes post CRTD, we have often noted that there is a proarrhythmia just because you have implanted a LV lead. Sometimes if it's just a post CRTD patient implant in ward, you have got an ES, you have to shift to cardiac ITU, you may have to switch off the LV pacing. And even sometimes you have to revise the LV lead. So, ES survivor without an ICD should get an ICD, but not at the time when they are in shock, when they are in ES. So once you manage the EF satisfactorily, before they go, definitely they need to get an ICD based on what the etiology is. In sometimes we may have to completely deactivate ICD. That is a very palliative approach, need to be discussed with the patient bystanders before doing that, and well documented before switching off the ICD. Most of the times when managed patient, either they go, their destination is either an ICD or an LVAD, or at least list them for a cardiac transplant. These are the usual out of hospital management of ES. So this can be a step care approach. Acute management, the most effective management is a DC cardioversion. Once we see a patient with storm running, first we may have to try to make them stable by cardioversion. If they are conscious and can be low sedation can be given, if they are stable enough to be given a low sedation, probably it's better to shock them. So electrical cardioversion is of prime importance, and that is most effective in intervention in acute termination of ventricular arrhythmia in an electrical storm. Antiarrhythmic drugs, of course, need to be started. All patients need to be on some antiarrhythmics when they come in a storm. So most commonly, it is a class 1 agents. The advantage of class 1 agents is that they reduce the automaticity. They actually reduce the electrical instability, excitability, and they slow the conduction. That's how they act. Class 3 agents, like IV amiodarone or sotalol, they inhibit the VT by prolonging refractory period, and they reduce the re-entry. So automatic VT is better is procainamide or lignocaine, while re-entry VT, IV amiodarone or sotalol is better. So these are the 4 agents mainly used. IV procainamide unfortunately is not available as of now in our country, but it's very useful in automatic VTs. They are useful. The problem is they cannot be given in the totally structurally. If the EF is like 10-15%, probably it's not a very good choice. You run up with VF, more of VF if you start IV procainamide. So IV amiodarone is better in this subset. It's not very useful in acute MI. IV lidocaine is better. And in advanced kidney disease, because procainamide keeps collecting in the body. So it is typically after initial IV amiodarone, we can continue before stopping IV amiodarone, we need to start the oral amiodarone. So there may be overlap. So to stop the IV amiodarone, patient has to be free of at least 48 hours from VT. So And lidocaine is often added as second line agent. One agent we can add these days is mexiletine. Oral mexiletine 300 milligram per day can be used as an oral agent. In addition, can be given to a rise tube in a ventilated patient. So that also helps, because the biggest advantage of lidocaine of mexiletine is it won't prolong QT. So if at all procainamide has to be started, amiodarone needs to be stopped. So other medication for continued therapies are beta blockers, as we know, and IV esmolol and are better, short-acting agents are better for patients on ECMO, on cardiac support. But at least propranolol is a very underused agent. It can be used for resistant VT-VF syndromes because it also reduces excitability by mild sodium channel effect. Sedation is required. Benzodiazepines, opioids, dexmedetomidine is a very useful agent, or GA in refractory cases. One another thing is a stellate ganglion block, which you can do in cardiac ICU if you have an ultrasound nearby. Just locate the C6 carotid tubercle and give injection in so that we can see the carotid artery, avoid the vasculature, and just behind the carotid artery above the vertebra, you can locate you can inject some 5 to 10 ml of lidocaine without adrenaline. And it should be unilateral, because if you give bilateral, sometimes you can land up in bilateral diaphragmatic palsy and prolonged ventilation. So to avoid that, initially give unilateral, especially in conscious patient, but sedated patient you can go ahead and give a bilateral. And the aim is to minimize inotrope dose. If at all noradrenaline is safe, vasopressin and phenylephrine are other safe agents. And mechanical cardiac support is required in many patients. It helps in many of the patients so that you can easily manage them. Suppose you can't manage with inotropes, but rather than go on escalating inotropes, better add one of the mechanical support IABP. A percutaneous ECMO is very useful. If you do a percutaneous ECMO, you may have to upgrade, call the surgeon next day and escalate it to a central ECMO, VA ECMO, because otherwise LV will go on dilating, it will increase the arrhythmia. So sometimes, very rarely, permanent LVAD or these things may have to be used, but very rarely. This is one of our patients who has a 46-year-old MI who had to be ablated. He's a evolved anterior MI, PCA done elsewhere, but came in VT storm. We had to take up, we did a left cardiac central ganglion block. Still VT was only burden reduced. So we used an ICT after catheter ablation on ECMO. Because patient was arrested, brain was almost totally gone. After ECMO, next day he became conscious enough to talk. So on ventilator he was conscious. So we took up and ablated scar VT. In such cases, while we ablate, there is of course a pain SD score to decide on whom to take up for ablation in ES. So very bad patients we need not take up. And ablation is essential in such a situation. When we ablate, it's a minimalistic approach. We just need to stop the VT at that point of time. We need not go for perfection. So sometimes if you can do an activation mapping, it is good. But otherwise, just modify the substrate, get out of the lab as soon as possible. But when you do, you can do a core isolation or a scar homogenization, which takes time. But if they are on ECMO, you have the time to do that. And then you can do a complete job by complete the substrating ablation and map each of the late onset activity so that at least the VT stops for the time. At least VT burden can stop. And this patient, we had to place an ICD immediately, and then he slowly improved on ECMO.
Dr. Praveen, can you summarize your talk now?
Yeah, I've already over. So rare VFs can be ablated if they have a triggering PVC, and you should have a planning a definitive therapy using a multidisciplinary approach. We may have to call surgeon and need to do sometimes palliative end of life care is what we have to do with patients by shared decision making. Thank you.
Thank you very much. Nice talk, covered each and everything. One point I just want to make, overdrive atrial pacing.
Yeah.
Overdrive atrial pacing. If suppose a single chamber ICD, so you can do a temporary pacing in the atrium, or if it's a dual chamber ICD. So you can do an atrial overdrive pacing that helps to stop the storm also. Any question from the floor? We can take one question. Or any comment?
Superior. Especially propranolol is a very underused drug.
Correct.
Yeah.
Propranolol is superior in suppressing VT as compared to metoprolol. So
So all these studies are there. So beta blocker is preferred, and in acute, esmolol is preferred in acute stage, and then or you can switch over to the non-selective beta blocker like propranolol, long-acting now.
Esmolol we use mostly when they are on ECMO because it can be easily adjusted.
No,
dose adjustment.
even on IBP you can give these drugs and they can tolerate very well. In these patients, your aim is to not to VT occur or VF occur. That's the aim, and they tolerate very nicely. So, and then left state ganglia block by bupivacaine. We don't give lidocaine because lidocaine effect is very transient. So we give bupivacaine and it lasts for 24 to 48 hours. Till then it subsides, the electrical storm subsides.
Instead of lidocaine, we have been increasing using mexiletine in our center.
Yeah, you can
Oral
add.
mexiletine load at the time when they are in
Beta blocker,
casualty.
along with beta blocker you can add, but amiodarone I don't think is of.
Okay, thank you very much. So I would like to invite Dr. Bharatraj is going to deliver talk on role of imaging in VT ablation.
Good afternoon, chairpersons and all my colleagues. So, I'll be speaking on the role of imaging for ablation of ventricular tachycardia. So, VT circuits in structural heart disease are inherently complex, and mapping VT in the setting of structural heart disease, which are reentrant VTs, is possible only in a smaller proportion of patients because of hemodynamic instability. Hence, VT in structural heart disease requires more of a hybrid approach with more focus on substrate modification, and this is where the role of imaging becomes critical. So, I'll be discussing about MRI, CT and ICE in the management of non-ischemic cardiomyopathy. So, this is the classic re-entry circuit. However, it is quite simplified. So, you see there is an entrance, there is a central slowly conducting channel and there is an exit. However, in patients with non-ischemic cardiomyopathies, many of these circuits are often three-dimensional with critical components located in the mid-myocardium and in the epicardium. So, coming to the role of imaging, the first step is to delineate the type of cardiomyopathy, whether it is ischemic or whether it's a non-ischemic cardiomyopathy. And then subsequently, further subclassify non-ischemic cardiomyopathy since it's a very heterogeneous entity. So you got hypertrophic phenotype, you got dilated phenotype, you got arrhythmogenic cardiomyopathy with either RV or biventricular involvement. You can have valvular cardiomyopathies and then inflammatory cardiomyopathies and also genetic cardiomyopathies which can manifest in different phenotypes. So this is a workflow for evaluation of patients with non-ischemic cardiomyopathies. So when a patient presents with a monomorphic VT, so the first step is to try to understand what is the underlying substrate. So history, 12-lead ECG and transthoracic echogram will be the first line of investigation. So history is important here. Family history of sudden cardiac death in the past gives a clue that probably this is a genetic cardiomyopathy. It can be either hypertrophic cardiomyopathy or it can be a dilated cardiomyopathy related to one of the cytoskeletal proteins. The next step, once we have the basic information, the next step is to perform a cardiac MRI. So that gives us anatomical information regarding the scar location and the extent of scar burden, so which has prognostic information as well. So alternatively, we can perform a cardiac CT and a PET scan to delineate, especially when you are suspecting inflammation. And then intraprocedurally, once you have this information, intraprocedurally we can, we always often use the 3D mapping system. And then the importance of this imaging information is that it tells you whether you have to take epicardial access upfront in addition to endocardial mapping. So coming to the role of ECG, ECG will tell us the chamber of interest. RBB morphology ventricular tachycardia probably is exiting from the left ventricle, whereas LBB morphology tachycardia with a late transition, probably the exit is in the RV free wall. And then there are several criteria for localizing epicardial VTs. I'll not go into details. So it all means that the initial part of the QRS is delayed. That is the reason you get delayed R wave peak time and a long RS interval and long maximum deflection index. And another important sign is presence of Q wave in lead 1. So it generally suggests the exit is on the epicardium. And then it has been observed that idiopathic dilated cardiomyopathy generally fits into two different categories, although there are many more subtypes, but the more common one are the ones with basal anteroseptal scar, and the second more common phenotype is the basal inferolateral scar. So ECG can give us clues regarding these two phenotypes. So ECG signs include presence of AV block or presence of left bundle branch block or a wide QRS. So more fascicular involvement, it suggests that the scar is probably in the anteroseptal region. Likewise, dilated cardiomyopathies which are post myocarditis, generally they tend to have a scar in the inferolateral segment, and it is usually subepicardial. And ECG signs include low QRS voltage in the limb leads, presence of Q waves in inferior leads, fragmented QRS in lateral leads, and prominent S wave in V6 and R wave in V1. So many of the times, often these patients are implanted with a defibrillator, and then you don't have a 12-lead ECG to analyze the VT morphology. So we can always go through the stored EGMs. So one important clue is regarding the VT cycle length. So that will tell us whether it's a stable VT or whether it is going to be hemodynamically unstable VT, and then you have to completely avoid inducing the VT. Second thing is to look at the far field, near field interval. So there is a paper from the Marklinski's laboratory where they found that if the far field to near field interval is less than 30 milliseconds, then it probably suggests that it's an anteroseptal scar and probably an endocardial exit. However, if the interval, the far field EGM to near field EGM interval, if it is more than 60 milliseconds, then probably it suggests an inferolateral exit or an epicardial exit. So this is the diagram from their paper. So you can see the onset of the far field EGM, and then you look at the onset of near field EGM. And then if it is less than 30 milliseconds, yes, it is endocardial. And then if it is more than 60 milliseconds, then there is high probability there is an epicardial exit. However, you can see that there is a significant overlap in the 30 to 60 millisecond range. So this is inconclusive. So coming to cardiac MRI, this is the most important imaging tool which is available to us for patients with non-ischemic cardiomyopathies. It delineates the VT substrate. It tells us the location, whether it is endocardial, mid-myocardial or subepicardial. And then accordingly, we have to plan our access strategy, whether to go with epicardial upfront or not. And MRI is always superior to transthoracic echocardiogram in detecting mural thrombi. So again, which can be a complicating factor in planning ablation. Moreover, we get additional information regarding pericardial adhesions, pericardial pathologies, and presence of subdiaphragmatic anatomical variations or pathologies such as diaphragmatic hernias or enlarged liver. So these points are very important when you are planning an epicardial access. And then there are segmentation softwares which allow us to integrate cardiac MRI sequences into the 3D mapping systems. So just a few examples. So in ischemic cardiomyopathies, generally you get a transmural scar. So here a transmural scar located in the anteroseptal region. Likewise, there is a endocardial scar in the inferior septum here. So again, these are patterns which suggest that it's ischemic cardiomyopathy. Coming to non-ischemic cardiomyopathies, you can see here there is significant hypertrophy of the left ventricle, and there is a mid-myocardial scar in the panel A. So this is a hypertrophic cardiomyopathy with mid-myocardial location of the scar, which is quite typical. Sometimes you get patchy scar also. Then coming to the B panel, you can see here there is a subepicardial inferolateral scar. So this is a patient post-myocarditis with cardiomyopathy. And then in the third panel, you can see there is a subepicardial scar involving the inferior segment and the inferior septum. So this is an example from a patient with inflammatory cardiomyopathy, which turned out to be cardiac sarcoidosis. And then in this panel, you can see there is a mid-myocardial, which is classical of idiopathic DCM. And then this is panel E is amyloid. So there is a circumferential subendocardial enhancement. And then finally, in the last panel, you can see there is a enhancement or late gadolinium enhancement in the RV free wall. So this was a case of ARVC. So LG is the foundation of cardiac MRI, which tells us the presence of scar. In addition, T1 mapping can be used to look at myocardial edema and active inflammation. In some patients in whom there is a defibrillator which is not MRI compatible, we can always go for CT imaging. CT can tell us transmural scars when the myocardial thickness is less than 5 mm with hypoattenuation, so it suggests a ischemic scar. However, in patients with non-ischemic cardiomyopathy, CT is slightly less reliable and less useful. However, the location of coronary arteries, veins, phrenic nerves, and the location of epicardial fat are excellently depicted by cardiac CT. Coming to intracardiac echo, it's a very valuable tool for certain arrhythmias, especially if you want to visualize intracavitary structures like the pap muscle, false chordae, and the moderator band. It gives us real-time information, guidance during transeptal access, helps in visualizing the coronary ostia and the proximal coronaries, guides the operator during ablation. It gives real-time information regarding catheter contact and stability. And then you can monitor lesion formation and if there are any steam pops or any complications such as pericardial effusion. And then with the CARTO sound, it can always be merged with 3D anatomic mapping. So this is a case of posterior pap muscle PVC being mapped and ablated using intracardiac echocardiogram. You can see here there is a green tip which indicates good contact of the ablation catheter with the tip of the posterior pap muscle. So ICE is definitely invaluable in pap muscle VTs. And ICE can also suggest the presence of scar. Suppose you have an eco-dense structure in the mid-myocardium and epicardium. So it is likely to be the source for ventricular arrhythmia. So you map in this area and you are likely to find diastolic channels. So I'll just show one case which we did a couple of years back. A young male diagnosed with ARVC, and then he had recurrent VTs. Initially he underwent ICD implantation, but then presented to us with recurrent ICD shocks. So this was the MRI. We showed a scar in the inferior segment of the RV in the subtricuspid region, and there was some scar in the RVOT also. And this was the VT morphology which we induced in the EP lab. So you can see here there is LBP morphology with late transition and then with a northwest axis. So we mapped, the VT was hemodynamically stable. We mapped in the RV initially endocardially and then epicardially. So endocardially we could not get any good diastolic signals. In the epicardium we got signal. In the basal RV we got a continuous fractionated signal. And then we performed entrainment and then it showed a very short post-spacing interval with concealed fusion. And the stim to QRS was long and equal to the EGM to QRS. And then ablation at this site terminated the VT. So ablation guided by imaging is quite beneficial in patients with ARVC, and generally they do well if you do proper substrate modification. So this is the epicardial map, and this is the site where the VT terminated, where we had a good entrainment. Although the ECG suggested there is a apical exit probably, but then the VT actually was ablated in the basal RV, in the infralateral portion. And this was the endocardial map. Again, the region of scar is quite, still there is endocardial scar. We had to do substrate modification in the endocardium also. However, the extent of scar is higher in the epicardium compared to endocardium. So patient is doing well on follow-up. So coming to our ARVC experience, we have done almost 13 cases in the last 7 years. And then we used combined epi-endo approach in 10 out of 13 cases. So on follow-up over 5 years, one patient had a recurrence, and this patient had undergone only endocardial ablation. We did not go epicardially in this patient, and patient came with a recurrence. And one patient we lost because of progressive RV failure. Otherwise, all patients are doing well, especially patients who are young, they are doing well. So just to conclude, this is a comparison of MRI, CT and ICE. So you can see that MRI is useful for detection of fibrosis and scar, whereas CT is useful for delineating calcium and also for coronary visualization and also for epicardial fat. ICE gives real-time information and for especially gives good imaging of intracavitary structures. So to conclude, I would say that imaging is essential to understand the substrate in patients with non-ischemic cardiomyopathy, and this is critical to plan the ablation strategy, whether to go endocardially alone or to take upfront epicardial access, which makes things easier actually, rather than taking epicardial access at a later time after heparinization. So upfront epicardial access should be taken in patients with non-ischemic cardiomyopathies, especially ARVC and cases where there is subepicardial LGE on MRI. And then ICE is vital for ablating ventricular arrhythmias from endocavitary structures. There are numerous publications on this, although my personal experience is quite limited with ICE, but literature definitely supports use of ICE for PAP muscle VTs. So I'll stop here. Thank you for your attention.
Thank you, Bharatraj. Is there any questions from the floor? Bharat, a wonderful talk. Just one question, like all these substrates of ARVC and all, you do an activation map in epicardium, you find the site, you ablate it. How much of substrate modification in the epicardium you do in these cases? Because it's an evolving substrate, you said you do a substrate modification in the epicardium. You will find a lot of scars, and also how much of substrate modification in the epicardium you do, or you just do the focal ablation for the epicardial VT and come out?
We tend to be as comprehensive as possible. So based on the voltage mapping, we do extensive ablation, almost like scar homogenization, rather than ablating only in the focal area. As I said, it's an evolving substrate, and if you want good, durable, long-term results, then you have to ablate as much lavas or abnormal potentials as possible.
Bharat, in absence of ice, do you think any role of 4-dimension transesophageal echo for papillary muscle VTs?
Yeah, transesophageal echo also gives you real-time information. Definitely, it will be useful, but then again, you have to intubate the patient. You have to do the procedure under GA if you want to do, if you want to insert a esophageal probe. So that can suppress the arrhythmia most of the times, because these are quite sensitive to anesthesia and sedation.
Thank you very much.
Thank you.
We'll go to the next talk by Dr. Suresh on bipolar ablation. What needs to be careful?
Good morning, respected chairpersons, seniors and dear colleagues. At the onset, I would thank the organizing committee for giving me an opportunity to talk on this topic, bipolar ablation, what need to be careful. As we all know, radiofrequency ablation is the pillar of non-pharmacological treatment of arrhythmias. Unipolar ablation is considered to be the gold standard in the treatment of majority of arrhythmias. A minority of arrhythmias, be it from atrial origin or supraventricular or VPCs, they can be unreachable. It will be a challenge for RFA, especially if the VTs and the VPCs arising from the intramural or the epicardial structure, then it will be difficult for going with a unipolar ablation. So in these cases, bipolar ablation has the potential ability to create deeper and more transmural lesions. But the safety of the bipolar ablation remains a concern due to the potential it can have on the potential collateral damage. So before going on to the topic in detail, we must understand what is the principle of unipolar versus bipolar ablation. As we all know, there is a patch on the back of it, and there's a radiofrequency energy current density decreases as the distance of the catheter is away from the patch. So because of the dispersion, the energy decreases. So sometimes by unipolar ablation, we cannot reach the adequate levels. We cannot get a transmural lesions. So what happens in bipolar, if you see here, the two catheters are in contact with each other, and they will not be in any patch. So what you will do, you will bypass the patch, and the circuit will be closed by the jumper cable. One cable is to the ablator, and another cable, the other electrodes, it is to the jumper cable, and the circuit is completed. In that way, you can have a transmural ablation. So what are the indications? In late 90s or that time, bipolar ablation was used for left lateral axillary pathways. So, but then as there was more of complications, it has been obsolete. Again, it has gained importance in the case of mitral isthmus related arrhythmias like mitral flutter or atrial flutter, CTI dependent flutter, where you could not achieve a complete bidirectional block, you needed a bipolar ablation. Or in 10 to 12 years back, phased RFA for AF it was done, where multiple electrodes were used for the mapping of the pulmonary veins, and you can give energy either by unipolar or bipolar. And one case I had to come across where patient had an incessant SVT, was ablated 10 years back, and then he had recurrence. He had patient had manifest pre-excitation, and in spite of doing unipolar ablations multiple times, he was having symptoms, and I had no other go than to try for bipolar ablation. So this was published in the last year Journal of Arrhythmia, which I presented as a complex, challenging case in APHRS. So in this, if you can see, the SVC end is the active end, the IVC end is the returning electrode. So during bipolar ablation, the pre-excitation disappeared. These are the signals you can see here, and then could have sinus them. So 1.5 years post-procedure, patient is doing well. So now coming back to the ventricular, so this is the ECG pre and post. So coming back to the ventricular arrhythmia session again, so the indication is complex and often performed in redo cases. Prior unsuccessful ablation with unipolar ablation for VT originating from interventricular septum. The patients who have deep substrate, as we have heard the previous talk, we can understand the substrate by imaging like cardiac MRI. So if deep substrate is identified, then these subsets of patients, if they are not beneficial by unipolar ablation, bipolar ablation can be tried. Outflow tract VPC and VT, if they are not amenable to unipolar ablation, bipolar ablation can be done. The other one is the LV summit ventricular arrhythmias. So in this, if we have to reach the anteromedial LV summit, the active catheter, the ablation catheter should be in the LVOT, the returning catheter should be in the RVOT, and if we want to reach the inaccessible LV summit, then the active catheter should be in the LVOT and the returning catheter should be in the pulmonary cusp. And if you want to reach the lateral LV summit, and if you see that the earliest signals are in the great cardiac vein in the coronary sinus, then you have to have the active electrode in the active catheter in the LVOT, the returning catheter in the GCV. So this is how you can approach a LV summit ventricular arrhythmia. So what are the concerns during bipolar ablations? The effectiveness of bipolar radiofrequency ablation, then coronary artery damage, the cardiac tamponade and the steam pop, and the AV block in the vicinity of the His bundle. So I would like to touch all these points. So coming to the effectiveness of bipolar ablation, the distance between the two catheters is less than 15 mm, then it is an indicator of great success. And if the distance is less than 15 mm and you achieve a contact force of 10 grams, then you can achieve a transmural infarct. And if the distance is more than 20-25 mm, the contact force should be 20 grams. You must ablate for more duration, and the chance of creating complications will be there. So this was a study done in the animal study. You can see the lesion epicardial and endocardial depth was maximum when the distance was less than 15 mm. When if it is more than 20 mm, the distance between the catheters is no good than a unipolar ablation. So is there any role of catheter orientation of bipolar radiofrequency ablation? Yes, definitely. Both the catheters are perpendicular in orientation to the myocardium, the deeper lesions are done. So in animal studies it was seen, so both the catheters are kept in perpendicular as well as in the parallel condition. And the ablation was done in unipolar mode as well as bipolar mode. So they have seen that when bipolar ablation done perpendicular orientation, there is transmural lesions. So the other thing which we more fear is the coronary artery damage. So how to prevent that? Coronary angiography wherever applicable, and you should ensure a safe distance from both catheter tips more than 5 mm. Then power settings in the GCV should start from 10 watts and titrating up to 27 watts. Achieve impedance drop of 10%. The flow rate should be 8 to 15 ml per minute, and temperature should not go more than 39 degrees per centigrade. And ablation should be stopped if the impedance drop is more than 20%. So how to avoid the steam pop and cardiac tamponade? The perpendicular oriented catheters and irrigated should be the active catheter, and ground tip should be preferably 8 mm catheter or an irrigated catheter again. And the powers should be less, and this will be creating a largest and deepest lesion without steam pops. If you use the 8 mm catheters, the active catheter, ablation catheter, steam pops or more. So this was a study done, and when the active catheter is 8 mm catheter, it leads to more complications. So another study which was seen, which confirmed that the returning catheter, if it is 8 mm, it is beneficial. So active catheter 8 mm is not advisable, but active whereas the returning catheter 8 mm is advisable, or a irrigated catheter. The other thing which can prevent steam pops and complication, as the previous speaker has told, intracardiac echo. If we can see a rapid increase in tissue density in eyes, then we have to stop it. And OIS also helps in improving the stability of both the active catheter and the returning catheter to track inaudible steam pops. So if we have to ablate in the vicinity of the His bundle, that is septal VT, from both the right ventricle and the left ventricle, we have to first of all see the exact His bundle location both in the fluoroscopy as well as in the 3D mapping. There should not be presence of any His electrogram, either far field or near field, in both the catheters. If there is any doubt, place and see. And bipolar radio frequency ablation should be starting at low power settings, 10 watt power settings. And if any fast junctionals or VA, if it is there, then you have to stop it. So I showed two cases. The first case, a 36-year-old female presented with recurrent palpitations and pre-syncope for more than a year. She underwent ablation elsewhere, and she is symptomatic in spite of having undergone ablation and antiarrhythmics. Echo showed bicuspid aortic valve, moderate AR, and moderate LV dysfunction. So she had a VPC-induced tachycardiomyopathy or arrhythmia-induced cardiomyopathy. You can see here outflow tract VPCs. So EF is 41%, AR was moderate. The VPC burden was 38.2. So as she was on antiarrhythmics and symptomatic, I had to take up her for EP study. This is a baseline ECG in the EP lab. You can see the VPCs were there, bigeminy was running. And then I tried first left cusp slightly, it was 30 milliseconds earlier to the QRS. I ablated there, but it used to go and again come back. So there was recurrence. Then I tried in the GCV. I could get success, but then it used to turn back. Then I thought maybe it's a intramural. The MDI was more than 55. Then this was a bipolar setup in the lab. Then EGM at the ablation site, good EGM, 42 milliseconds earlier to the QRS in the VPC. And I took an angiogram. So in the angiogram, you can see definitely I felt it was much more than 5 mm then away from the OM, and other catheters also away from the LMCA. Two orthogonal views. And then the power setting was started at the 20 watts. And the temperature was 43 degrees centigrade, and for around 19, this impedance drop was there. In 1 minute I had given, and then this is the catheter set. We can see it is slightly perpendicular, the orientation. So after 1 minute I did the angiogram. You can see circumflex, there is pinching. Though patient did not have any pain, no ECG changes, I stopped. There were no VPCs. So I felt intra-procedural angiogram should be done after 30 seconds of bi-RFA rather than doing for 1 minute. And this, the post-RFA, this is ECG. There was no VPCs. Repeated the Holter after 48 hours. She was fine. And then the LV function also improved. She had ejection fraction of 54%. Echo was done after 1 month. And then after 1.5 years, again she developed symptoms. Slightly the VPC burden was high. Then I knew where was the site, but then I was worried about the coronary arteries. So before going to the procedure, I did the coronary angiogram. To my surprise, there was no pinching. So that could be a vasospasm at that time. So 60 seconds I had given, so not done much damage. So, and this time, this patient underwent aggressive EP study. I had given isoproterenol, atropine, everything, but I couldn't induce a single VPC. So kept the patient on medical management, and she's doing well. The second case, a 54-year-old male, similar presentation. He has a bicuspid aortic valve, severe LV dysfunction. ECG showed outflow tract VPCs. Holter showed 26.4%, 2 to 3 morphologies, and this was the ECG. So I took him up. Again, I couldn't get success in the left cusp and then the great cardiac vein, and planned for bipolar ablation. And during ablation, the patient, the VPC was terminated. And if you can see, this catheter orientation was more perpendicular to the myocardium. So I could get success, and the patient was VPC free post-procedure. And echo also improved, and is on follow-up for last 6 years, is doing well. The ejection fraction improved to 48%, and his spine is doing well. So concluding, bipolar radiofrequency ablation has the ability to create deeper lesions than unipolar ablation. It is safe with excellent outcomes, but we must be cautious about the complications. So careful titration of power and maintenance of the safest distance possible from the sites of potential collateral damage must be done. Constant monitoring of the impedance and distance between the two catheter tips is crucial. Intra-procedural coronary angiogram is must to ensure safe distance from both catheter tips. I feel that after doing 30 seconds, better do a coronary angiogram rather than waiting for 1 minute. Thank you.
Thank you very much, Suresh. Any experience on, if you're talking about the pathways, the most difficult are the right free wall pathway?
So I did the one I presented that in the last year APHRS, it was accepted as challenging pathway. It was right lateral pathway. So
how did you go? One endocardial, one apical, or one is below the annulus and one above the annulus?
First I did a routine way where IVC and I went, everything is endocardial only, sir. So what happened when IVC and I used to get transient success, again reconnection used to be happening. Then I changed, I went from the SVC and I tried SVC and I could get reconnection maybe after 10 minutes or so. Then I thought something is happening intramurally. Then I thought SVC and one active catheter and IVC and the returning catheter, and I could get success.
So where did you place both the catheters? Above the annulus or one below the annulus?
Yes, one above the annulus. So this
one
is
below.
you can see the one, it was there. If you can.
Okay, got your point. Thank you.
No, sir. Yes, sir. Yes, sir.
So, Suresh, when you do that, when you have both from IVC and SVC, you're on both on the AV, even if it's on atrium and ventricular side, you're not doing it bipolar across the annulus. So this is an epicardial, you're not getting the pathway on the same side, both sides. Now, if you do epi-endo, it's fine, understood. But you're doing on atrial side and ventricular side, and this pathways are usually epicardial fibers. So how do you get it bipolar on that?
See, from the I mean to say atrial end and the ventricular end. So I have used the bipolar circuit. So I felt like the pathway will be deep seated within the annulus. So my power is not being achieving. So by keeping both the catheters this way, I could get the good penetration, and within I think 10 seconds or 15 seconds it went off, didn't come back. But it is never reported. This is I have sent for heart rhythm case reports also. It is under review. So not reported. Only pathways, postoceptal pathways has been done, bipolar ablation, by keeping in the ventricle, both sides of the ventricle or atrial ventricle. But postoceptal has been described, but right free wall has not been described.
After you finish the...
Sir, before one more thing. Before doing, I did coronary angiogram. After completion, I did coronary angiogram because it's near to the coronary artery, right coronary artery. So I was very, after completion also I did coronary angiogram.
Did you check the CS?
CS, the levo phase we see, it was good enough.
It was all right?
It was all right.
What was the power in both the catheter?
For SVT?
No, for VT. Ventricular.
I started with 20 watts.
What about the, why not use half-strength saline?
Sir, I don't have half-strength saline. So
half-strength saline is available everywhere.
No, we are not having at that moment.
Pediatric fluid is one of the half-strength saline.
Yes, sir.
I was commonly available.
I was not having.
I have similar case, but instead of bipolar, I use some half-strength saline.
Even D5 also, it has been in the papers they have showed D5 also gives a deeper lesion. So I came to know while
D5 is dangerous.
So in the
5, it may lead to rupture.
Futiyama et al.
POP is very common with the D5. That's why D5 is not used clinically, only done experimentally, that it causes deeper lesion.
Okay, I think we'll close the session.
Thank you, sir.
All the speakers have done a wonderful job. Thank you very much.
Thank you so much, chairpersons and honorable doctors, for this session. I think it's time for us to again re-energize ourselves. So please give a big round of applause because we've been here since morning. I would request everybody to please give a big round of applause for all the sessions because we are almost nearing towards the end. But yes, again, one more session left. So let's proceed towards that. It's the AF session 3. And for this, I would like to invite on stage the chairpersons, Dr. Preetham Krishnamurthy, Dr. Kirtika, Dr. Amit Malik, and Dr. Arun Gopi. A warm welcome to all of you on stage. And now we'll have our first speaker who's connected with us online, Dr. Dheeraj Gupta. Thank you so much.
Just to make an announcement that we have two talks in this session, Dr. Dheeraj Gupta followed by Professor Ravi Chakraborty. Then we'll have the award session. We are hoping to start the award session by 1:25. Thank you for the patience.
I think Dr. Dheeraj Gupta is already online. So we have Dr. Dheeraj Gupta talking on dispersion mapping and rotors in persistent AFib. Yeah.
Good afternoon, everyone. Thank you very much for the very kind invitation to contribute to the Indian Heart and Lung Society meeting 2024, Calcutta. It's a pleasure to join you all from Liverpool. I've been asked to speak about dispersion mapping and rotors in persistent atrial fibrillation. So we know that most persistent atrial fibrillation also has drivers from the pulmonary veins. Pulmonary vein triggers are still the most important contributing factors in persistent atrial fibrillation as well. What wasn't clear in the past was what was the proportion of patients who developed atrial fibrillation from extra pulmonary vein sources. We showed many years ago that even if you achieve durable pulmonary vein isolation, as many as 1 in 5 patients with early persistent atrial fibrillation had failure of ablation strategy. So they had AF recurrence at 12 months. Then we recently published this study in a much more advanced cohort of persistent atrial fibrillation patients with dilated scarred atria. And we saw that the efficacy of durable pulmonary vein isolation was even less good in this cohort. So as many as 40% of patients, in spite of documented durable pulmonary vein isolation, continued to have AF recurrence on follow-up. We also know that performing extra pulmonary vein ablation empirically has not really been shown to be beneficial, at least in multiple randomized controlled trials. Most have had disappointing results. Even posterior wall isolation has not been shown to be effective. The only strategies that have shown some benefit in randomized controlled trial setting are ethanol vein of Marshall ablation, left atrial appendage isolation, and hybrid ablation. But again, these results haven't really been validated in other studies so far. Therefore, there is a need to personalize your ablation strategy to the individual patients. This can either be to target anatomical scar, which could be detected either by electroanatomical mapping or with MRI, or to target functional scar, functional AF substrate, which you can detect based on various mechanisms. Over the past decade or more, various tools have been developed to map atrial fibrillation drivers, including firm mapping, ECGI system, which used a multi-electrode vest for phase mapping, or a Cuter system, which used charge density mapping, and a Cartofinder, which many of us may have used, which uses unipolar signals and subtraction analysis in the Carto system. There were many studies that assessed the role of these systems in trying to improve outcomes. And each one of them showed promise in single-arm or single-center cohort studies, but the results were not widely replicable, and hence each one of them have fallen by the wayside. Which brings us to spatiotemporal dispersion. Now, the concept of spatiotemporal dispersion was first described by the group from Marseille in France in 2017. This alludes to an ensemble of EGMs forming a localized sequential activation in a distinct area. Electrograms are collected from both left and the right atria using a multipolar catheter with contact mapping. The catheter is held in place for at least 30 seconds then is sequentially moved inside both chambers. Representative examples of some sites showing spatiotemporal dispersion in 4 different patients are shown in this diagram. You can see in bipoles exhibiting continuous fractionated electrograms in B as well as C. And if you look at if you look at the red arrows, it shows that there seems to be a sequential activation of consecutive bipoles in a multipolar catheter spanning almost 100% of the AF cycle length. Now, the VOTA system has been developed that automates this process and is now integrated in the EnSite mapping system. As this very brief video shows, it essentially tags in blue all the sites where it thinks that there are areas of electronautomedical dispersion. You deliver ablation there. In this particular case, the AF was transformed to the perimitral circuit, and ablation here on the anterior mitral circuit essentially restored sinus rhythm, as you will see there. Now, furthermore, as with any other AI tool, this system learns continuously. As this database continues to replenish itself, it becomes better and better and more predictive of the future as well. Now, although it was developed in Marseille, dispersion mapping using the VOTA system underwent multi-center validation in the EFib, AIFib multi-center studies were published a couple of years ago. Basically, 8 centers, 18 investigators studied this system. Biatrial AF mapping was done, and then ablation was delivered at the dispersion sites. And what was interesting was that if you look at the outcomes in the original cohort of patients in the Marseille group, as well as the other 7 centers, they were absolutely identical. So what this study showed was that the VOTA system, it can be used in a variety of operators with the same results as the ones who originally helped to develop it. Now, but as we have seen with other mapping and ablation strategies before, the real proof of the pudding lies in validation through a formal randomized controlled trial. And the Taylor AF trial studied this. So it studied 374 patients with advanced persistent atrial fibrillation. These were randomized to either an anatomical approach with bungee vein isolation alone in the index procedure, or a tailored ablation strategy in which these sites of electronautomedical dispersion were targeted along with bungee vein isolation. At the time of redos, with the tailored approach, patients continued to have the same strategy, whereas in the anatomical arm, they could have up to 2 other linear lesions. All of these patients underwent very intense follow-up of 12 months with daily ACD monitoring. It was a very advanced subgroup of patients. Most of them had either persistent or long-standing persistent atrial fibrillation. The left atrium was dilated. As you can see, the maximum duration was more than 6 months in a majority of patients. In the procedural characteristics, the procedure time was inevitably longer in patients in the Taylor AF arm. Rather than an hour and a half, it was more like 3 hours, so the procedure duration was almost double. Clearly, this meant that more mapping time was necessary, and obviously the radiofrequency ablation time was much higher. But importantly, in the lab, there was a much higher proportion of patients whose AF terminated with ablation, either to atypical flutter or indeed to sinus rhythm. Importantly, over follow-up, the group that was randomized to the tailored ablation arm did far better as compared to the anatomical arm. The results of this randomized control trial were presented at the Heart Rhythm Society meeting earlier this year and are in press, and they should be published later this week. So to summarize, empirical extrapulmonary vein ablation strategies have limited benefit, and hence there is a renewed interest in physiological or personalized ablation prescriptions. AI-guided ablation spatiotemporal dispersion sites are promising, but we obviously need more experience to integrate these mapping systems and workflows into our day-to-day practice. Thank you very much for your time.
So, yeah, wonderful talk, sir. Just wanted to have 2 questions. So, is there any in these, when you're dealing with these persistent AFibs with the addition of this AI-based dispersion mapping, does your LA cutoff, are there any LA cutoff sizes, or are there any MRI-guided scar volumes that define that you take them out of these studies?
Well, most of the randomized controlled trials have had a cutoff of a left atrial size in the parasol long axis view of 5.5 centimeters. Now we know that the left atrium is a globular three-dimensional structure, and the parasol long axis view often underestimates the actual degree of left atrial dilatation. But for all its flaws, it's still used as a gold standard for many randomized controlled trials because it's so easy to measure. In clinical practice, of course, you can have a whole range of patients who you can offer AF ablation to. As I showed in one of my slides, with the laudable study, we had patients who left atrium even more dilated than 5.5 centimeters. But obviously, the results, success and the outcomes are less good the more the dilated the left atrium is. In terms of MRI-guided scar ablation strategy, we know with the DCAF2 trial that this was not useful, but also it's been extremely difficult for many MRI centers to be able to ascertain the amount of atrial scar. Even in Liverpool, we have tried for a long time, but whereas MRI is fantastic to assess ventricular scar, as we just saw earlier in the previous session, it's almost imperative when you're planning VT mapping. Whereas in AF ablation, AF mapping, we have not been able to really use MRI to guide our strategy.
So just one more question. So we tend to see a lot of valvular atrial fibrillation. So with if an AA-based dispersion mapping comes in, which are able to take up the substrate in the left atrial body as well, do you think we were not at all aggressive of PVI in valvular AF? Do you think this will have a role in that kind of substrate as well?
See, as with any AI tool, it gets better the more you use it. The more the number of patients go into its database, where it identifies where are these sites of electroanatomical dispersion, where ablation terminates the atrial fibrillation, it tends to improve on the output it gives you of subsequent patients. So I have absolutely no doubt that there is a role to be used for valvular atrial fibrillation because this is a very difficult subgroup, as you said. That, just pulmonary vein-based strategy often is not effective in this group. So I'm obviously very excited about using Volta for this group. Obviously, time will tell whether it will improve outcomes in this difficult group of patients.
Are there any questions from the audience? If there are no more questions, thank you, sir, for the excellent presentation. We'll move to the next talk. AF management in India. Is the rhythm management still underestimated? By Dr. Robin Chakravarti.
So good afternoon. I presume I'm the last speaker of the session, I believe, for the whole conference. So a kind of a pre-valedictory talk. So I'm going to talk something called AF atrial fibrillation management in India. Is a rhythm management still undervalued? So this is a kind of epidemiology of atrial fibrillation, which was published from the Indian authors, as well as in comparison with and in compilation with others. And it tells us clearly that global community of prevalence of atrial fibrillation is roughly about 0.5 to 5.5%, depending upon the group of patients which has been taken into consideration for this epidemiological study. If you look at the Indian scenario, the Indian population-based information on atrial fibrillation is limited, I have to say that. But whatever little information that we have today, it shows that studies in India show prevalence of ranging from 0.1 to 1.6%. But I personally feel this is still like an understatement. It could be more because in our clinical experience, we do see patients, especially beyond 65 years of age, both men and women, perhaps more in men, coming with atrial fibrillation with some kind of background of cardiovascular substrate. But this is the kind of data that we have. And there are multiple risk factors. I'm sure that you all know about it. Could be obesity, hypertension, sleep apnea, lipidemia, coronary artery disease, obesity, so many. So they are being called in general the substrates of atrial fibrillation. And it is important for us to understand this substrate because unless you know the substrate, you cannot plan a strategy for treatment. So, and the classification of atrial fibrillation as of the latest information from European Heart Journal this year shows that first diagnosed atrial fibrillation, paroxysmal atrial fibrillation, persistent atrial fibrillation, and permanent atrial fibrillation. And this is the kind of a pillar, 3 pillars of atrial failure management. This could be stroke risk assessment. So assess the stroke risk and treat, optimize the modifiable risk factors, and try to understand the atrial fibrillation burden of an individual with background of substrate and other thing, and then you decide how to go for the rhythm management or rate control. And this decision is just not a decision. It is a kind of commonly called as shared decision-making process, where you consider the risk factor assessment, and then also you talk about the behavioral changes, and then you take into account the background of heart failure, smoking, exercise, obesity, hypertension, ethanol, diabetes, and sleep, so many things. And this is a very important slide in the sense that when we talk about the rhythm management in the Indian scenario, I think both the patient's population as well as the physician, including the electrophysiologist, need to understand, even the electrophysiologist, they have to recognize that they have a clinical responsibility to treat heart rhythm. They are all extremely good in doing ablation. But beyond ablation, there are certain clinical responsibility that they have to undertake, because that is an important component of treatment of the patients, because we are eventually doctors. We treat patients. We are not technicians. So that is the reason why all these factors must be taken into consideration to plan the management. And this is a kind of very common slide. I'm sure maybe in this conference it has been shown a number of times, the 4S and ABC of atrial failure management. So I need not sort of broaden it further, which essentially means stroke risk, symptoms, severity of atrial fibrillation burden, and substrate severity. And then you talk about anticoagulation to avoid stroke, you talk about symptom control, you talk about management of comorbidities, cardiovascular risk factors, and management. So taking these consideration, and there are a number of points which has to be considered, and then you decide that this could be the right way of approaching this particular patient's atrial fibrillation, be it rhythm or maybe the rate. Now, if you fail in this kind of tabulation or this kind of understanding, then obviously the ideal management you will miss. Because you miss the ideal management because you miss the basics of the genesis of atrial fibrillation. Because atrial fibrillation, unlike PSVT or unlike AVNRT or like AVRT or even fascicular VT, is a completely different thing because there are multiple substrates. And that must be taken into consideration before you decide to go to plan a management, and which is of paramount importance. This is a kind of guideline which we have. I mean, I think this is the latest guideline perhaps, and it talks about the age, this kind of, where exactly the rhythm management would be the ideal one. Age less than 65 years, pregnancy, tachycardia-induced cardiomyopathy, and number of minor structural heart disease, disabling atrial fibrillation symptom, few morbidities or increased stroke risk, and so many of them. And at the same time, when you have a patient of atrial fibrillation, think of the patient that this patient has come to you with irregular heartbeat, with episodic palpitation, or maybe kind of it comes and goes, an occasional heartbeat, whether these patients, some of these patients may not have anything. So that is called without any symptoms, whether with symptom and without symptom. If you identify the patient and then you find this patient has got symptom, then it goes to one direction. If the patient doesn't have symptom, then it goes to another direction. So you categorize the patient, classify your patient, and find an algorithm. And there's a very nice sort of demonstration that if this patient has symptom and has got younger of age, the first episode, the tachycardia-mediated cardiomyopathy with a normal increased LAVI or atrial conduction delay, and no or few comorbidities, rate control may be difficult to achieve, or atrial fibrillation precipitated by a temporary event like acute illness, or discuss with the patient and explain to him and then take his point into consideration. This subgroup may be a good case for rhythm management. This is very simple, very straightforward, and then plan accordingly. And then you go for it, and then you have to understand that if you really seriously take this rhythm management pathway, you have to be very clear. Then that has been shown categorically in the literature that by doing so, you can reduce the stroke incidence by 35%. you can reduce the mortality by 16%. And that is important. So the early initiation of therapy results in lower progression from paroxysmal atrial fibrillation to permanent atrial fibrillation. And this is a kind of data that we have, which I again said. So earlier days, we used to see the non-permanent atrial fibrillation. So instead of talking about persistent, paroxysmal, or even permanent, it could be, make it simple, permanent atrial fibrillation and non-permanent atrial fibrillation. If it is a non-permanent atrial fibrillation, then you think about that what we used to do earlier and what we should do today. If it is a non-permanent atrial fibrillation, if the patient has symptom, then you can think of rate control. If the patient continues to symptom, you can have rhythm control. So these subgroup of patient can have either rhythm control or rhythm and rate control together. So there is a group of patients where you can have both rate control and then patient is continuously non-responding, then you can actually consider rhythm control. So the very simple message is, if you decide that this particular patient goes for rate control only, it is no longer tenable. It can be both rate control followed by rhythm control. So rhythm control is there because that has shown to improve the mortality, to improve the hospitalization, and improve the heart failure and other complication. And that is important. And there are various ways this rhythm control can be achieved: cardioversion, pharmacological, electrical, and so many, which I'm sure that in this meeting people discussed. So we need to remember it. And very common practice, what I find amongst physicians in particular, and some of the non-electrophysiologic cardiologists, that they tend to use amiodarone in atrial fibrillation. Probably it's a good drug, but not a good drug for every case of atrial fibrillation. That has to be understood, that has to be recognized. And accordingly, you decide that yes, if you find that it's a good case for cardioversion, go for cardioversion. Do not hesitate. There should not be any inhibition of cardioversion. That is important. And then after that, you can think of the cardioversion followed by pharmacological and continue the therapy, and then you decide to go for catheter-based ablation. And ablation, I'm sure that many such talks were there. There are various antiarrhythmic drugs. Some of the drug has to be given on a long-term basis, and you get a good drug at the moment, even in India. And ablation EP mechanism we already discussed a number of times, and there are various advancement of ablation. And from like when we started, it was a very sort of simple but very crude way of pulmonary venous ablation. From there, three-dimensional technique, and nowadays we are talking about artificial intelligence guided electrophysiological mapping and pulmonary venous ablation, or sometimes extra PV ablation. So this is a kind of overall. If you look at the Indian scenario, this is the data. I think this is the catheter ablation of stroke. We know about the Kavana study and other things. This is the Indian data. This has been published sometimes in 2016, and it has shown that from the Indian subgroup, this is a real world data. This is a kind of observational study, has shown that there are situations like non-CNS embolism, major bleeding, heart failure, arrhythmias, transient ischemic attack, stroke, and even acute coronary syndrome. And then out of these, the rhythm control was done only in about 1/3 of the population. A good number of these patients actually had rate control. And rhythm control and rate control was practiced only in 0.3%, which is certainly disturbing. But this is a wake-up call for the electrophysiologist, for the cardiologist in Indian scenario. And about nearly 20% of the patient had nothing. So clearly it is being undervalued or underused. So the way I think, so this particular paper published in Indian Heart Journal concluded the cross-sectional observational survey of real-life clinical practice demonstrates that atrial fibrillation is not adequately controlled in India with the appropriate choice of antiarrhythmic drugs. A good proportion of patients who are at high risk of a stroke do not receive anticoagulation. These results highlight the need for improved antiarrhythmic drugs and antithrombotic treatments for optimal management of atrial fibrillation. So to conclude, in my opinion, for the rhythm management of atrial fibrillation in India, I think what is important is the early identification of the substrate. Like today's hypertension, in 10 years of time, is going to present to you with atrial fibrillation. Today's diabetes, obesity, and background of ischemic heart disease, you have done everything. You have done angioplasty, you have taken control of diabetes, but the obesity is there. He is going to come back to you with atrial fibrillation. So identification of substrate is important, early identification, aggressive management of substrate. How many people, we take history of sleep apnea, of patients with hypertension, sleep apnea, he's going to come back to you with atrial fibrillation. So those substrates need to be identified, need to be evaluated, and then make a plan for assessment. Screening of premature atrial ectopic. Sometimes a hypertension patient comes to you, and then you can occasional ectopic, and did an ECG, find one ectopic. Do not ignore that. That is the beginning of the atrial fibrillation. We have to understand that. So screening of premature atrial ectopic in those substrates is important. Motivation of rhythm management as the first line of therapy. Motivation for the physician, for the cardiologist, and for the patients. This is a wonderful thing. I think long time ago, sometimes 15 years ago, I gave a talk. Maybe you people may not be know about Thomas and others. Anil probably knows. I gave a talk when I talked that that is the eighth wonder of having sinus rhythm of your heart. So motivation of rhythm management as the first line of therapy. Early initiation of therapy for rhythm management is important. Don't be reluctant. DC cardioversion is a good thing, at least to bring it back to sinus rhythm so that you have time to work up and plan for the long-term rhythm management. Pharmacological management, catheter-based management is important. Atrial fibrillation is an important cause of morbidity and mortality. You have to remember that. Patients' education, family physicians' education, motivation, and initiation of the process is important. Your desire or intention for rhythm management in atrial fibrillation is of paramount importance. Thank you very much for your attention.
That's a wonderful talk. So, sir, just to understand, actually, if you look at the rhythm control strategies that we use and the Westerners use, there's a real huge volumetric difference of the number of procedures that we do for rhythm managing strategies on AF and what happens outside India. What do you think is the reason for it? Is there a real difference in the incidence and prevalence, or it is just that we are missing out a lot more of things that...
I think you just echoed my thought. It's exactly the same thought which I was thinking while making the preparation of the slides. What has happened, the data that you have between rhythm control and rate control, I have to say, this is a little old data. We do not have any current data with a newer modality of treatment of atrial fibrillation by rhythm management. The newer modalities are excellent, and their rhythm management success rate is good, the control rate is good, and I have to say that those data, whatever we have in the literature, actually did not consider the management of substrate in a good way. So if you really take the management of substrate right in the beginning, and then follow them up for a longer period of time, I'm sure you will find the difference.
So, Deepa.
Thank you very much, sir. Very important talk, though the last talk, in the Indian perspective, because the landscape we see as youngsters, the landscape of atrial fibrillation is changing, and in the other 10 years, we'll be in a whole new platform talking more about atrial fibrillation, just because the cardiometabolic profile of India is changing. Rhythm control, as you had mentioned, is very important for the non-permanent, that as you had termed, and also for the non-valvular AFibs. Rhythm control should be the primary, and unfortunately that still many of them continue to be on just rate control medicines with the AFib neglected, and that should not happen. Electrophysiologists as such, we do not want bad outcomes of ablation as well. So whenever we take a patient for ablation, I think the patient in most of our centers goes through a screening clinic, and we make sure the obstructive sleep apnea is addressed with proper CPAP adherence, hypertension is addressed, and weight reduction. So without doing all this, our outcomes also going to be bad. The outcome of ablation is not only the ablation, it's about how you manage the patient as a whole. And the other subset, AF in heart failure, and we have studies showing that in heart failure patients, it could be HFpEF because we see more of HFpEF nowadays. And in these subset of patients having atrial fibrillation, even if it is a hypertrophic cardiomyopathy, they benefit. And the message to the patient is very clear. We are not trying to cure atrial fibrillation here. We are just trying to bring down the burden and give a better quality of life along with stroke prevention.
Very nice comment, and I just add to that, if you really actually look at the heart failure management data, even with the early intervention of heart failure, if you really look at the data, the rhythm, the abnormalities, volume has come down, burden has come down. So that has to be addressed. because the heart failure can be a consequence of arrhythmia, or it could be also a result of this could be both.
So thank you, Dr. Robin. If there is no more question, I would like to close this session, and thank you very much for a conclusive and wrap-up talk. It can't be better than that. Thank you, sir. Thank you.
Thank you, respectable doctors. And now it's almost towards the end. So once again, let us have a very big round of applause and congratulate each and everyone present over here after a 3-long hard day and successfully completing the 16th annual conference of Indian Heart Rhythm Society, Kolkata. So now I would like to call upon Dr. Debobroto Bera, Dr. Suchit Majumdar and Dr. Rakesh Sarkar to please come over and proceed with the next sessions. Thank you so much, ladies and gentlemen.
So we had a very intense discussions in the last 3 days. Our theme was definitely translate the translational, and I think I can remember this is one of the recent conferences which has looked at it in a separate way, and there were significant international and national faculties looking at that. Now, before we go for the final and valedictory session, we have the prize distribution session. That is very important because there were a lot of oral and e-poster presentations in these days. And I can tell you that all were very good quality, and it is very difficult for the judges also to decide that which is good and which is less good. So, but anyway, we have to mark and we have to announce the winners of the groups. So what we'll do, we will do the different categories and we'll announce the winner as 1, 2, 3. And there will be prizes also for the first candidate. So for the prize distribution, I would like to request Dr. Anil Saxena sir, Dr. Anup Gupta sir, and Dr. Raja Selvaraj sir to the dais. Dr. Ajay Naik sir. Yes. So I think Dr. Debobroto and Dr. Rakesh have done the work of collating the scores and then finding who is the best out of them. So Dr. Debobroto, you can announce.
Yeah. Thank you so much, Suchita, and thank you all of us for being with us till the last day. And it was a complex Excel sheet, as good as a very complex CAR-VT ablation. Still, we had to make some decisions, and we have come up. If I, by mistake, enumerate the name or the spelling wrong, please bear with me. We will start with the oral abstract presentation. Oral abstract presentation, we had 7 categories. So we will start with, if anyone is not present, some of his colleague can collect it on the behalf. So conventional EP category, the first prize goes to Avinav Anand. If you are here, please come over. Raja sir, please do the favor. So there are T-shirts. Presently we are giving it. You can exchange it with your friends or our registration desk according to your size, please. Thank you so much. The next prize goes to Dr. Subham Sharma in conventional EP. If you are there, please come over. Just to prepare the next to expedite the session, may I request Dr. Raghav Bansal. He is the 3rd in the conventional EP group. Raghav, please come. So Raghav comes 3rd in the conventional EP group. Have a big round of applause, please. Yeah, please make a big smile during the photo shoot. So now we are going for 3D session set 1. The first prize goes to Ushnish Adhikari. Ushnis, if you are there, please come, or any of his colleague wish to collect it. Okay, Rakesh, can you collect it on his behalf? So Rakesh is going to collect it on his behalf. Yeah. Thank you so much, Rakesh, for helping me out. Yeah, thank you so much. Just keep it for Ushnish Adhikari. The second prize goes to Anish Bhargava, please come in front. And the third prize goes to Aditya Mulgaonkar. Aditya, if you are here, yeah, please be ready after Anish collects his trophy. Thank you so much, all of you, to enrich our academic knowledge. All of them were very, very high quality presentation. Aditya, please come. After this, we are going to announce the 3D set 2. 3D set 2, the first prize goes to Jashkaran Gujral. A big round of applause, please. So it was truly a very competitive thing, so that our list of awardee becomes long, but we have tried to give and inspire as many as youngsters possible. The second prize goes to Dr. Devendra Bisht. I think he's not there, so he can collect his trophy for Dr. Devendra Bisht. The third prize goes to Dr. Arun Gopi. So Dr. Arun Gopi, please. A big round of applause from him and his center. They had the maximum number of submission this time. In fact, we had to cut down some of his representation in some of the sessions, to be honest. Yeah, more than 12 or 13 submission. Coming to the device section, the first prize goes to Amira Sheikh. Amira, please come over. You had the maximum number of representation and submission. She's from Dr. Gopi's team. So the next prize goes to Dr. Shomu Bohra. Dr. Shomu Bohra has already left because of the early flight. If anyone, Raghavya, please collect it. Be ready to collect it on behalf of Dr. Shomu Bohra. And the third prize will go to Dr. Kaushik Manna. Please ready after the prize of, yeah. Take your time to have a good big smile during the photograph, please. Yeah, Raghav, please come over on behalf of Dr. Shomu Bohra, our inspiring colleague and teacher. Yeah. Dr. Kaushik Manna, please. Yeah, a big round of applause for Kaushik. Now we are going to the next section, that is nightmare section, oral abstract presentation. The first prize goes to Yogesh Kulkarni from CMC Vellore. Yogesh, yeah, please come forward. Many congratulations to you and your team. The second prize in this segment of nightmare goes to Muthaiya Subramaniam. I think Muthaiya has left. Yeah, on behalf of him, his colleague will collect the trophy. Please be patient during the photo shoot. Don't move. And we have enough time to give you the awards. So on behalf of Muthaiya, his colleague has collected the award. Thank you so much. The third prize goes to Amit Malik, Dr. Amit Malik in the nightmare section. Dr. Amit Malik, please. A big round of applause again. It was a very interesting device case, we must say. We had multiple submissions. We had to select, had a tough job. Coming to the next segment, we are going for a study abstract. So the first prize goes to Sai Kiran Kakarlara. Sai Kiran, please come. A big round of applause again. It was a very interesting study. You all should read the study. It's from the prestigious center of Suchitra. Yeah, the second prize goes to Shanmuga Sundaram. So I think Shanmuga is not there. Anyone from Madurai, can you collect it on behalf of Dr. Shanmuga? Okay, we are keeping it for Shanmuga. And the third prize goes to Dr. Sindhu Rao Malla. I think, yeah, Dr. Sindhu, are you coming? Yeah, please come. Take your time, no hurry. Dr. Shanmuga Sundaram, we are keeping the award. Yeah, Dr. Sindhu, please come. So we are finishing the oral abstract presentation here, and we are moving to oral allied professional. So in oral allied professional, we had very tough fight, very interesting cases today morning. We'll going to the EP section first. The first prize goes to Miss Selva Maheshwari. Please come forward for the first prize. In fact, she had more than one presentation and both of them were equally good. We had to choose between two of them. The next second prize goes to Bharat Krishna. Bharat is from the prestigious Institute of JIPMA, and along with Sharon Jeb Malar. So both of them stood second in the EP Allied Professional EP group. Yeah, Sharon Jeb Malar, please come forward for the second prize. Take your time during the photo shoot, don't move please. And the third prize, again there was a tie in third prize. So let's have a big round of applause for Sharon. She has also had more than one presentation. The third prize goes to Shobhik Jana and Anushri Bhattacharya. Both of them stood third with the equal numbers, equal scores with 3 judges in fact. Please come forward. So this completes the EP oral category, and now I'm going to announce the EP device category of Allied Professional. Yeah, please come forward. Yeah. Shobhik Jana first. Shobhik Jana and Anushri Bhattacharya both are third. One by one you can go and have your photo. And certificates will come online to all of you within the next few days. Yeah, Anushri, please. So in the device category, a big round of applause please. In the device category, Nibin Manu stand first. Nibin Manu please. Yeah, Nibin is coming. Nibin also has more than one presentation. And second comes Surya Vasan. And third is Sharan Kumar Ji. So I'm proud to say that many of them come from Triple M and Kaveri Hospital, Chennai. It's such a rich institute and rich city to have so many EP and EP technicians. Now we are going to go to the E-Poster Award in the day 1 EP poster. Okay, let's have the photo shoot first. Sharan Kumar Ji now. A big round of applause please for Sharan Kumar Ji. Okay, now we are going to E-Poster Awards for day 1. We have first prize in the morning session goes to Dr. Apurva. If you are here or any of your colleague can collect it. You are collecting on her behalf? Yeah. Okay, so on behalf of Dr. Apurva. So she stands first. Please a big round of applause please. The second comes Avinav Mohave. Avinav Mohave, if you are around. Yeah, he's coming. Avinav Mohave please. Yeah. So and the third prize goes to Shobhik Sardar. Shobhik, are you around? So Avinav Mohave comes second in the E-Poster session. Shobhik is not here. Please keep the award. We are going to the next session, evening session of day 1. The first prize goes to Amruta Hari, Dr. Amruta Hari. I don't see Amruta Hari coming forward, so I'm going to the next. Oh, sorry, I'm extremely sorry. So we'll wait for her. And the second prize goes to Venkatesh Gurjala. Venkatesh, are you around? Yeah, okay, come. And the third, Dr. Vaibhav Mishra, please wait for your turn. I think Vaibhav is not here, so on behalf of him, his colleague will collect, his friend will collect. Now the award goes to Venkatesh Ji. And on behalf of Dr. Vaibhav Mishra, you are? Karan, okay. Please go ahead, yeah. On behalf of Dr. Vaibhav Mishra in the third prize on posters. Now coming to day 2, the first prize goes to Dr. Shomu Bohra. He is not here and Raghav will collect. Next time onwards, we have prohibited him to collect any award, Dr. Shomu. So Raghav, you can collect on behalf the first prize for poster session 1. The second prize goes to Dr. Avinav Agarwal. Dr. Avinav Agarwal, are you around? And third prize goes to Dr. Preeti P. Dr. Preeti, are you around? Yeah, please come. So this completes the day 2 morning session, and the day 2 evening session. The first prize goes to Dr. Dinakar B. So big round of applause for Dr. Preeti. The next prize goes to the poster evening session. First prize goes to Dinakar B. Second prize goes to again Amira Sheikh. Amira, are you around? And the third prize is a tie. Third prize goes to Gokul and Sai Vishal. Mr. Gokul and Mr. Sai Vishal. In the evening poster session day 2. Coming to the final section, day 3, morning session posters. So Gokul and Sai Vishal, are you around? Yeah, please come. So both of you had a tie. So you get the third prize. Please come forward one by one. So this is the third prize for the poster session yesterday. And coming to day 3, morning, yeah, please. Gokul and Sai Vishal gets the third prize for the yesterday's poster session. So day 3, today's morning session, the first prize of e-poster goes to Velayutham R. Velayutham, are you there? Okay, please come. Velayutham goes first, Monisha gets second, Dr. Monisha KG, and third is Dr. Nivedita Chakrabarti. So Velayutham comes first. This is the final session. A big round of applause for everyone. All who have submitted, who has been selected or non-selected, we are proud of them. The second prize goes to Dr. Monisha KG. And the final prize goes to Dr. Nivedita Chakrabarti. So some of them have an overlap of topics. So you have not mentioned the topics. It will be written in the certificate. Thank you so much. I hand over the mic to Dr. Rakesh and Dr. Suchit. Thank you so much everyone for the award session.
Shall we begin our valedictory session then? Yeah. Dr. K.K. Talwar, please. Yes. Can you join us? Eta iye dite hobe. Chair down, একটা chair. হ্যাঁ একটা স্টেজে দাও স্টেজে ওই তো প্লিজ দেবব্রত So I think let us start the valedictory session. So we have tried our best and we have tried to do this conference at our best as a part of the team from Kolkata. I, Dr. Devabroto, then Dr. Rakesh and Dr. Sanjeev Mukherjee. And all good things should come to an end definitely. So after these 3 days of brainstorming, we have to close this conference and maybe we'll look ahead to the next conference of IHRS. So first I think, so I would like to thank all the faculties, international and national faculties who have come from long distances to participate in our conference. We would like to thank all the presenters. There were actually, I think, around 150 total abstract submission, which is a huge number. And then we had to select oral and then e-poster abstracts. So of all good quality, and now they have got prizes also for that. So scientifically, this scientific content of this meeting was good. Also, we tried to focus on the theme of the meeting, that is the translational EP. And there also we had the help of Dr. Pralay Chakraborty. And I think that was because research is something which is going to develop in India in future, and we should try it for that. So I think this is one way we expose the audience to translational EP. Now, many of us, we don't know that also. Now, this exposure was important, and I think this conference we tried to do that. So, apart from that, I would like to thank the industry partners who helped us for this conference. Especially, we like to thank Abbott, Medtronic, Biotronic, Boston, then Sun Pharma, Torrent, J&J, Novartis, Tasmed, USB, IPCA, Cipla, WebCardio, and Pfizer. Everybody has contributed for this scientific development, and then that's why we met and we could make this conference possible. Last but not the least, I would like to thank Mind Vision
who were our event management team for conducting this conference, and the hotel, Novotel, for helping us out with the halls and also the logistics. Our audiovisual team, led by Mr. Sunil and others, tried to do a good show. And we also had our travel partner who helped us to arrange the tickets of the faculties. So before ending the meeting, I would like to suggest if there is some comments on the meeting, some feedback, because anyway we have tried. I know there will be some flaws and we will try to rectify in future. Any comments, sir? Dr. Talwar, Dr. Naik, sir.
First, I must congratulate you and your team and the scientific committee. It was a very well-structured and a good scientific program, and particularly encouraging the youngsters. I think this was a prize session was that you see so many, that's good. I think the more we can invest into our younger generation and juniors, I think that probably is the major achievement should be. And then your hospitality is beyond description. Thank you so much. And I am sure that the way you also name the hall, that's good, I think, to our own colleagues who were with us, who really have been sort of working from the beginning for this particular section. Dr. Mohan, George Juneda, I think it's great that the halls were named on their names. That's good. Very original, innovative thinking on that. Well, I'll only say thank you so much, and it's a good program, and I hope that next meetings we have more and more constructive discussions on how we can strengthen this particular specialty and attract and ensure confidence in the youngsters who are coming to this particular specialty. Thank you.
Thank you, sir, for the kind words. I just made one mistake. I could not announce the prize winners of the yesterday's exciting quiz. So the first, I would say the other way. The runner-up for the quiz is Dr. Shubham Sharma and Dr. Apurva M. If you are here, please come. Please come, and sorry for the mistake, I skipped it. A big round of applause for them. A big round of applause. And then it comes to the winner of the team. The winner of the team is Dr. Jaswinder Singh and Dr. Yogesh Jagannath Kulkarni. Or Dr. Yogesh and Dr. Jaswinder. They had to be first. They are from the prestigious center of AIG Hospital and CMC Vellore. If you put together, I think they publish more than 30% of the total publication in all India. We are so proud of them. Thank you, sir. Thank you so much. Now it's gone over to Dr. Suchit Majumdar, please, for the concluding talks. After that, we open the lunch. Lunch is already open though. If you have an early flight, please join the lunch outside and be comfortable. We are joining you soon. Thank you so much.
So thank you for attending this meeting. I think next time we'll also have a IHRS, and we don't know where is it happening, but we'll have a scientific program and just like that. So thank you. Thank you, sir. Huh?